ENT, pharyngotonsillitis. It includes both pharyngitis as well as tonsillitis. So what we are studying now is includes or it validates for both pharyngitis as well as tonsillitis. Most of the time they kind of present together. There will be pharyngitis as well as tonsillitis. Tonsillitis is these are the tonsils. You can see they're quite inflamed. There are some pustular discharge is present. This is the posterior wall of the pharynx, which is inflamed, red in color, what you're seeing. So usually in the normal layman's term, they call it as in sore throat. So they can present with a sore throat. It is an infection and inflammation. So they can be a fever associated with it. If the posterior pharyngeal wall or the tonsils are inflamed, then there will be mild dysphagia. Rather than calling it as a dysphagia, it is an odonophagia, what we call it. That is painful swallowing. Whenever they swallow, even the saliva, if they swallow, it will be painful because that part of the mouth and the oral cavity is inflamed. Viral infections like Epstein-Barr virus can cause it. Bacterial infections, group A beta hemolytic streptococci is important because it causes various complications, what we have studied in our dermatology chapter. Whenever a patient presents with tonsillitis or pharyngitis, we tend to use an fever pain criteria. This is the most famous one, and you need to always use fever pain criteria unless in the stem of the questions they specify particularly that use centers criteria. Otherwise, do not use centers criteria, just use fever pain criteria. Fever pain criteria, what is present in the fever pain criteria, you can remember it as fever, F, and pain. In that mnemonic, you can remember it where F stands for fever. Presence of fever, that is spike of temperature in last 24 hours gets an point. Presence of any discharge from the tonsils gets 1 point. That is a purulent discharge, what we are talking about, yellow color pus discharge. And these symptoms have been rapidly developed over 3 days. That gets another point. Tonsils appears quite inflamed. They are enlarged. They are more reddish in color. Gets another point. There is absence of cough. There is absence of coryza. That is inflammation of the mucus of the nose. So absence of cough is very important. That gets 1 more point. So this one are 5 points. Here you get only 4 points. Any tonsillar exudates are present. Any enlarged lymph nodes, that is cervical lymph nodes, are present. History of fever is sufficient here and absence of cough. Each one of this following will get a single point. Using these points, either you will be not giving antibiotics at all, or you're giving backup antibiotics, or you'll prescribe an immediate antibiotics. These are all oral antibiotics, what we are talking about. First, we'll be talking about fever pain criteria. In fever pain criteria, if the score is between 0 and 1, we do not prescribe any antibiotics at all. Clearly explain to the patient that antibiotics is not required at all. Okay. If the score is between 2 and 3, then we give backup antibiotics. We tell them if there is no improvement with the symptoms in last 3 to 5 days, or the symptoms get worsened, then you can start taking this antibiotic. Otherwise, avoid taking the antibiotics. Last one is the score between 4 to 5. For fever pain score 4 to 5, you prescribe the antibiotics immediately. Every patient you are discharging, you need to do a safety netting. That is basically you will tell them if you feel more sick and the symptoms get worse and you're toxic appearing, you cannot take anything orally. At that point of time, do come back to the emergency department immediately. What about centers criteria? In center score, you can be just prescribe them, not prescribe them the antibiotics or just prescribe them the antibiotics. There is nothing in between where we do not give an backup antibiotic. For example, if the center score is between 0, 1 or 2, then we just go ahead and tell them that antibiotic is not required. If the center score is 3 or 4, you do go ahead and prescribe the antibiotics. Depending on findings what you are having, you can suspect if there is any complications or the what is the possible organism which is involved. For example, if there is an PTK on the hard palate, what you can notice, then you can suspect it to be an infectious mononucleosis caused by Epstein-Barr virus, basically, or you can suspect an group A beta hemolytic streptococcal infection, also known as strep pyogenic. If there is an unilateral swelling of the tonsil is present, and behind the tonsil, if there is some collection is there, suspect an quinsy, which is also known as peritonsillar abscess. Gray pseudomembranous membrane is present in the throat. We have already discussed this is a diphtheria. Strawberry tongue, we have two differential diagnoses, either the scarlet fever or Kawasaki's disease. We are aware of both of these conditions. Remember that scarlet fever is a complication of group A beta hemolytic streptococci. Posterior pharyngeal wall swelling is present. For example, neck swelling is present. Posterior wall swelling is present. Some neck pain is present. Okay, the mobility of the neck is hampered. Suspect it might be a retropharyngeal abscess. Whenever a patient has an abscess, always suspect there should be an high grade fever associated with these conditions. Sometimes a patient might have presented to a triage just saying that he has a sore throat, but there might be an impending airway obstruction suggestive of a tripod position. Drooling of the saliva might be present. Mom has bought a 3 years old kid who is in the tripod position, drooling of the saliva. Mom might just say that there is a sore throat. So be aware of picking these critical cases and shifting them to the resuscitation as soon as possible. Evidence of antibiotics. What is antibiotic? If you give the antibiotic, how it will be effective? Antibiotics makes very little difference for how long the symptoms last for. What about the complication? Does it prevent complications? No, it doesn't prevent anything complications. If you withhold also, unlikely the patient will have any complications. If you give the antibiotics, having adverse effect due to the antibiotics are high, especially nausea and some amount of diarrhea might have those patients. So these parameters also you need to explain to the patient when you tell them no antibiotics are required. Convince them saying that the duration of the symptoms will not reduce. Unlikely the complications will arise if you do not take an antibiotic. The incidence of complications if you take or if you do not take antibiotics remains the same. If I prescribe you the antibiotics, chances of you having adverse effect of taking antibiotics like diarrhea and nausea will be on the higher side. In that way, you'll be convincing the patient antibiotics will not be required. You'll be convincing and you'll be discharging. What is the first choice of antibiotics is phenoxymethyl penicillin. If it is contraindicated or penicillin is allergic to the patient is allergic to the penicillin, at that point of time, clarithromycin can be prescribed. In pregnant women, erythromycins are preferred. There should be penicillin allergy and as well as and penicillin allergy and pregnant women. At that point of time, erythromycin is preferred. Otherwise, in pregnant women, also you can give phenoxymethyl penicillin if they are not allergic to this drug. What are the investigations for tonsillitis or pharyngotonsillitis for that matter? No investigations is required most of the time. If the patient has severe infections or there are any predisposing factors like immunosuppression is present, at that point of time, you can get a throat swab done. Because if there is immunosuppression, chances of this patient developing complications like an scarlet fever or rheumatic fever are on the higher side. For that particular reason, it is recommended that either you get a rapid strep test done, you just take a swab, or get an ASO titer done. ASO titers, nothing but anti-streptolysin O titers, what you'll be getting it done. If you are suspecting an Epstein-Barr virus, then you need to evaluate further and see if you are suspecting an Epstein-Barr virus infection. We will be studying more about this one. ENT complications. ENT means the surrounding structures which are involved. So infection can spread to the surrounding structures. For example, it can go to the middle ear, cause otitis media. It can go to and peritonsillar. It can go behind the tonsils, causing peritonsillar abscess, also known as quinsy. It can spread to a retropharyngeal space, resulting in an abscess formation, or it can spread to the sinuses, resulting in infection. What about systemic infections? Systemic infections, both scarlet fever and rheumatic fever, is because of group A beta hemolytic streptococci. It can also result in kidney injury, that is glomerulonephritis also can be caused by group A beta hemolytic streptococci. Cellulitis, surrounding structures can have, but it is a rare complications. Infectious mononucleosis is nothing but it is secondary to an Epstein-Barr virus infection. Now let us see more about infectious mononucleosis. It is also known as glandular fever. Both means one and the same. Okay, infectious mononucleosis and glandular fever both means one and the same. It is caused by Epstein-Barr virus. This is not a notifiable disease, multiple times tested. We have learned this already in infectious disease. This is not a notifiable disease. Commonly seen in teenagers and young adults, it is also known as kissing disease. The main reason it is known as kissing disease is it is spread by sharing of the oral secretions. That's why it is very commonly seen in teenagers who tend to kiss each other. That's why it is also known as kissing disease. When do you suspect it? When the patient is having prolonged symptoms and fatigue associated with generalized lymphadenopathy. It is not only restricted to the cervical region, it is a generalized lymphadenopathy what the patient is having. Along with it, the patient will be having splenomegaly or hepatomegaly might be present. So anyone who is having a fever, along with it, he has a sore throat, that is pharyngotonsillitis is present. Plus, the patient is having a generalized lymphadenopathy. You are always suspecting an infectious mononucleosis in this patient. Some people who are at high risk, especially pregnancy or HIV population, should be investigated. In less than 12 years age group or someone who is immunocompromised, because he's taking chemotherapy or for any reason, if he's immunocompromised, serology is preferred. In any other age group, that means more than 12 years age group, it is preferred is monospot test, also known as Paul Burnell's test, also known as heterophile antibody test. They all mean one and the same. Let us see how to evaluate. So whenever there is a fever, there is an pharyngitis or tonsillopharyngitis is present, along with generalized inferior temperature is present, you're suspecting an glandular fever, also known as infectious mononucleosis. The first step is you get an heterophile antibody or the monospot test done. If it is positive, then you have a diagnosis. If it is negative, it cannot rule out. You will see the differential count, WBC differential count, and see the lymphocytes. If lymphocytes are more than 4,000, still there is a suspicion of infectious mononucleosis. If it is less than 4,000, then you can rule it out. If it is more than 4,000, go ahead and do an serology test. If serology is positive, then it is positive for infectious mononucleosis. If it is negative, then consider some other diagnosis. It rules it out. Remember that in less than 12 years age group, you're directly getting the serology done. What is the treatment? Most of the time, it's the supportive treatment which is required. Steroids are given only when there is a risk or there is an impending or there is a partial airway obstruction. So airway obstruction should be present for you to think about steroids. Otherwise, steroids you are not prescribing. Most of the time, steroids will not be required. Complications. This is known to cause hepatosplenomegaly. We are more worried about enlargement of the spleen. If the spleen enlarges, it, the patient will have abdominal pain. This is mainly because of the capsule of the spleen gets stretched. Whenever the capsule of the spleen gets stretched, they end up having pain. As it is an enlarged spleen which is there, it is prone for injuries. If the spleen ruptures, if the spleen gets injured, they bleed profusely. So we are very much worried about splenic rupture. For that reason, we tell them do not go ahead with any contact sports, including football, rugby. They should avoid it at least for a month. If they want to start playing before 1 month, any contact sports, they need to get an ultrasound scan done and rule out an splenomegaly. Otherwise, you're not giving any clearance for them to go ahead and play and contact sports at least for a month. Peritonsillar abscess, as I told you, one of the complications, it is also known as quinsy. Closely have a look. This is the tonsil what you are having. Behind the tonsil is the swelling which is present. That's why it is known as peritonsillar abscess. This is swelling is present mainly because of accumulation of pus. That's why it is known as abscess. They present with unilateral throat pain and there is difficulty in swallowing because it is enlarging in size. They have risk for airway obstructions. It can be large enough to cause complete airway obstructions. So closely have a look at this patient. If they are having any swallowing difficulty, drooling of the saliva is present, if the person is taking up a tripod position, especially in the pediatric age group. If the airway you are thinking might be compromised, suggested by the clinical findings what you are having, make sure the patient is in the resuscitation room and you have the ENT and the anesthetics available bedside before you even prick that patient because he might have an respiratory arrest at any point of time. No airway is not compromised. At that point of time, you can directly prick them, get an IV cannula, and give them benzyl penicillin, the antibiotics, IV antibiotics, you need not remember the name, and refer them to the ENT because this is an abscess. You need to do an aspiration and drainage for any abscess. So this requires an aspiration. Either they can do an aspiration or they need to do an incision drainage. The call will be taken by ENT surgeons. Post tonsillectomy bleed. Tonsillectomy bleed, there are various reasons for the removal of the tonsils. Okay, that is not concern for us. ENT has removed the tonsils and they have discharged the patient. They might come back to the emergency department saying that they have bleeding from the site of the surgery. If they present within 24 hours, it is a refractory bleeding what you need to suspect. That means the clot might have come off or a stitch which have been put up has come off. That's why the patient is bleeding. Delayed bleeding, that is after 24 hours up to 14 days post-operatively, it is known as delayed bleeding. Most of the time, it is because of the infection the patient is having. The patient is having bleeding in the oral cavity. Anyone having any bleeding in the oral cavity, the first step always is make sure the patient is upright seated. Otherwise, the chances of aspiration will be on the higher side. Then you'll be doing ABCD approach, making sure the airway is clear. Airway is clear, you're worried about. So airway and breathing with in circulation. If there is significant amount of blood loss, you might even have to do a blood transfusion. So for that reason, make sure you have a large bore IV cannula, 2 IV cannulas, get in full blood count, clotting profile, blood group, and cross matching done. Start with fluid resuscitation. If blood is available, start immediately with the blood. This is generic for any hemorrhagic shock. We'll be doing this one. Special thing you need to remember is any oral bleed. You need to make sure the patient is upright and do not give anything by oral. First thing is remove all the blood which is in the mouth by doing a simple suctioning. If the patient is alert enough, then you can ask the patient to do an hydrogen peroxide mixed with water, 1:1 ratio, and do an gargle. Okay, if his GCS is fine, otherwise the chances of aspiration will be there. You're not giving anything orally. In adults, what you can do is you can open the mouth and see the tonsillar bed where it is bleeding from. If you can spot it, cotton wool plug, basically a cotton piece, you will be taking, soak it with hydrogen peroxide or tropical adrenaline. Preferred one is tropical adrenaline because it is a powerful vasoconstrictor. Hold it in the forceps, apply pressure over the bleeding side, that is tonsillar fossa. You will be applying the pressure there. It will cause vasoconstriction, and most of the time it will help to stop the bleeding. If this doesn't occur, you can use the silver netted and cauterize if you can visualize and bleeding artery. If you're suspecting and delayed bleeding, make sure you give them intravenous antibiotics because this is most of the time because of the infection. And everyone requires an ENT referral here. Otitis externa. Externa means external auditory canal. Infection of the external auditory canal is known as otitis externa. It is caused by Pseudomonas or Staph aureus or Strep pneumonia. All this, they usually present with some amount of pus kind of discharge from the ear, along with some amount of itching might be there, and it will be painful ear. These are the classical presentations they present with. External canal, on examination, it might be inflamed, some debris might be seen, and it might be edematous. What you will be doing in the emergency department here is first clean all the secretions which are present. Okay, either you can do it by what is shown in the image by flushing, or you can just do an suction, then do an flushing, depending on how much debris are you visualizing. Then you can put an oral tab, sorry, wig can be placed. Wig is nothing but a piece of cotton or piece of gauze piece placed inside. If the secretions are significantly high, it helps to observe. One more thing is eardrops. You can place it here. It stays here for a longer time. That's the helpful, or that's the usefulness of placing an wig. If they have pain, provide analgesia. Tropical ear drops are preferred. Combination of corticosteroids and antibiotics is given. Aminoglycosides, you need to be careful if you're using in the ear drops. Make sure the patient doesn't have an tympanic membrane perforation before you give aminoglycosides, because it is ototoxic if it enters into the middle ear. So you need to make sure there is no perforated tympanic membrane before you prescribe them or give them an ear drop which has an aminoglycoside. Oral toilet, this is the toilet which is known as, basically you're suctioning out, clearing the secretions what are there in the ear, and you will be placing a wig. What is malignant otitis externa? The name, what it suggests malignant, it is not a malignancy. Whenever there is an infection by Pseudomonas, it can cause it can cause osteomyelitis of temporal bone. Okay, temporal bone is just adjacent to the external auditory canal. So it can cause infection of this temporal bone known as known as osteomyelitis. This is known as malignant otitis externa. If you're suspecting a malignant otitis externa, make sure these patients are admitted and you start them on IV antibiotics. Otitis media. Otitis media means the middle ear is infected. Middle ear, this is the part which is getting infected. It can be by strep pneumonia or Haemophilus influenza. In viral infections, it can be an RSV virus. Usually they present with earache. Some amount of hearing loss might be present, but most of the time hearing loss is because of recurrent infections of the middle ear. Non-specific symptoms are very commonly seen in young children. Okay, for example, 1 year old, 2 years old, they present with non-specific symptoms like irritable, poor feeding, lethargy, fever. If you have seen the pediatrician, whenever a kid of 1 year or 2 year or 6 months, less than 2 years, if they present to the emergency department, they usually examine the ear. because they are all non-specific symptoms. So it is better to have a look inside the ear. So what are you looking for inside the ear? You're basically looking for the tympanic membrane. The tympanic membrane will be bulging because of the infection in the middle ear. Along with it, there might be loss of light reflex. Light reflex is seen in anterior inferior quadrant. This is the quadrant. There will be light reflex. A cone of light will be seen here, which will be absent. It will be bulging and it will be more reddish in color. That is erythematous. It is all suggestive of an middle ear infection. Sometimes it might be even perforated and be having secretions in them. So how do we deal with this? Do we prescribe antibiotics for everyone? No, we do not prescribe antibiotics for everyone. There is a nice guideline what you need to be aware of. If the patient is having discharge, it is associated with an perforation. Discharge means there should be an perforation, otherwise you'll not be seeing any discharge in the external auditory canal. So if there is a discharge, then you can either give an backup or prescribe the antibiotics immediately. You need to take a clinical judgment. If this is under 2 years age group and both the ears are involved, again, backup or immediate you'll be giving. All these three circumstances, you will be giving immediate antibiotics. If the patient is septic, that means systemically unwell. If signs and symptoms are suggestive of a more serious illness, for example, it is associated with meningitis, then you will be prescribing antibiotics, then go ahead with the antibiotics. Has high risk of complications. That basically means anyone who is immunocompromised. If he is immunocompromised, he is at high risk of having complications, then you'll prescribe immediate antibiotics in these cases. If none of this following is present, no antibiotic is required. Whenever you're thinking of an backup antibiotics, that is in two circumstances where otorrhea is present in less than 2 years, bilateral it is infected, at that point of time, you need to tell them that if the symptoms doesn't improve in 3 days or symptom gets worsen, then you can start up with the antibiotics what you have prescribed. Here, first choice of antibiotic is amoxicillin. If the patient is allergic to penicillin group of drugs, then clarithromycin you'll be using. In pregnant women who are allergic to penicillin group of drugs, you'll be using erythromycin. What is the evidence on antibiotics? Antibiotics doesn't improve any symptoms. They have only little effect on the symptoms. They do not cause anything with the symptoms at all. Makes little difference with the recurrent infections. If you give antibiotic, does the recurrence of the infection will stop? No, it makes little difference. What about the complications? Complications are rare if you prescribe antibiotics, or if you do not prescribe antibiotics, doesn't matter. The complications are itself rare. Adversely, if you prescribe antibiotics, the chances of the patient having diarrhea and nausea are on the higher side. You can prescribe ear drops in middle ear infections, that is otitis media, if they do not have a tympanic membrane perforation. If they have tympanic membrane perforation, it is not recommended to prescribe ear drops at all because it will enter into the middle ear. Most of these ear drops are ototoxic because most of the ear drops, if you see, it is ciprofloxacin or it is one of the aminoglycosides you'll be using. Those are ototoxic. What about decongestant and antihistamines? There are no recommendation to prescribe and decongestant or antihistamines because evidence has shown that it doesn't help with the symptoms at all. They are useless. Prescribing an antihistamine like cetirizine is useless. Mastoiditis. Mastoiditis is basically mastoid process of the temporal bone gets infected. It is one of the complications of middle ear infection, what you need to be aware of. How do they present with? They classically present with behind the ear, it will be reddish in color because of the infection, and it will push the ear outwards and forwards. So you can see the ear is more outwards and forwards in this direction it will be. And they present with pain behind the ear where there will be a little bit of swelling and erythema will be present. You need to strongly suspect and mastitis in these patients. Pinna, that is the external pinna, what we are talking, or this should be forward and outwards. These are the key words what you need to pick up from the stem of the question. Because the pinna is moving forwards and outwards, external auditory canal gets narrowed. Most of the time, it is the failure of treatment of the otitis media. This is a complication of acute otitis media, what they present with. All these patients needs to be admitted under the ENT, urgent ENT referral will be required in the emergency department. You will collect the blood cultures. If there is any discharge, you will be collecting that discharge by swab and sending for the cultures and start them on IV broad spectrum antibiotics. Cholesteatoma. For cholesteatoma, for you to suspect in exam, there should be recurrent mention of recurrent middle ear infection should be present. That is, recurrent otitis media should be present for you to suspect an osteocholesteatoma. It is a complication of middle ear infections, and they usually present with an conductive hearing loss. So two things should be present in the stem of the question. Recurrent middle ear infection and conductive hearing loss should be present for you to suspect an cholesteatoma. Previously, they have given an image like this. This is nothing but keratinized tissue, what you're seeing inside the ear on examination. So this is the path what you're having. It gets infected, and over the time, keratinized tissue can get deposited there, which can be visualized. That image has been previously appeared in the examination. So what happens? It is nothing but erosive disorder. Because of an erosion, there is a keratinized tissue which presents. If you leave it without treatment, intracranial infections can develop. On examination, granulation tissue, what you're seeing here, will be appearing, and you need to admit all these patients and refer to them. There might not be a current infection. There might be only keratinized tissue which is present in them. Okay, surgical removal might be required. For that reason, you need to always admit these patients and involve the ENT surgeons. Tympanic perforation. Tympanic perforation, there are various causes. Barotrauma, it can be, as we have learned previously in our class, because of the diving, there might be pressure changes can cause barotrauma and tympanic perforation. There might be a direct injury to the tympanic membrane resulting in penetrating injury, or there might be a base of skull fracture resulting in tympanic perforation. There are various causes of it, but usually it spontaneously heals. So it is a perforation, it is a hole in the tympanic membrane. It spontaneously heals. You did not do anything for them. So spontaneous healing is there. The only thing is they need to be very cautious. Make sure the ear is clean and dry. If it is not dry, chances of infection are high. If they do not maintain the hygiene, chances of infection are high, and the infection will directly enter into the middle ear. That for that reason, make sure you explain them the importance of keeping the ear clean and dry, and they follow up with the GP. No admission, nothing needs to be done for these patients. Traumatic auricular hematoma, also known as cauliflower ear. This is very commonly seen in wrestlers. What happens here? Whenever there is an injury to the ear, there can be bleeding. Okay, bleeding, what will happen? Hematoma. Bleeding is nothing but hematoma will form. Accumulation of blood is known as hematoma. Whenever there is bleeding, it will be from the perichondrium because it is vascular structure. This perichondrium gets separated from the underlying structure, that is the cartilage. So perichondrium gets separated from that of the underlying cartilage. This cartilage is avascular. It doesn't have any vascularity here. So the blood supply comes from the perichondrium. If it gets separated from that of the cartilage, pericardium gets separated, then there is no blood supply. It will result in avascular necrosis of the cartilage. So it is important in the emergency department that you aspirate using a syringe. You will be aspirating this hematoma what is present. After aspiration, you will make sure you do a tight dressing. If you do not do a tight dressing, the bleeding might continue and then hematoma might develop within hours. For that reason, a tight dressing needs to be done so that there is no space for the hematoma to be developed. This is the importance of traumatic auricular hematoma, or this condition, so what you need to be aware of, and you'll ask them to follow up with the ENT. Epistaxis, also known as nosebleed, it can be a posterior epistaxis or an anterior epistaxis. Anterior epistaxis, most of the time, it is from the little's area. Posterior bleeding from the nose is mainly seen in elderly age group. What you'll be sending for? You'll be sending for full blood count. It is required mainly to look out for the hemoglobin levels. Blood group cross matching might be required if there is a significant amount of blood loss is present. Clotting profile, you will be getting it done if the patient has some clotting disorders or the patient is on any anticoagulant. You need to get this clotting factors done. What are the risk factors? Like for any bleed, the risk factors remains the same here also. The different risk factors, what you need to remember is hypertension can lead to a nosebleed. You need to be aware of. Previous cauterization or epistaxis can lead to it. Upper respiratory tract infections is one of the important causes. Dried mucus, usually they kind of scratch it, resulting in bleeding. Any foreign body in your nasal cavity, especially seen in the pediatric age group. Cocaine abuses, they sniff the cocaine, it can cause perforation and bleeding. Heavy drinkers, alcohol drinkers I'm talking about, can result in epistaxis. How do you manage this? Epistaxis it is, so it is bleeding somewhere from your face, chances of aspiration is there, so you need to make sure the patient sits up. That is the first priority, is make the patient to sit up. Soft part of the nose, if you touch your nose, the tip of your nose is soft spot. Only the tip of it should be compressed for at least 10 minutes. Okay, then observe and see whether the bleeding has stopped or not. Okay, that should be the first step. It is a first aid measure what you need to do it. Most of the time, paramedics would have done it. If they are directly have driven to the emergency department, at that point of time, you will be asking them to just pinch their nose for 10 minutes and re-observe and see. In the meanwhile, in the 10 minutes when they're pinching their nose, you can place something cold in their mouth. Why place something cold in their mouth? It can be an ice cube. Most of the time, it is an ice cube. You're placing an ice cube in the mouth because it will cause an vasoconstriction. If this is successful and the bleeding has stopped, what you'll do is you'll observe for another 15 minutes. There is no recurrence of the bleeding, then you can discharge them. No, the bleeding has not stopped. What you'll be doing? Use PPE first, because in the COVID era, it stress a lot because you're going close to the oral cavity here. Make sure you have good light source, that is, an headlamp is present. Remove any clots. First, when you're visualizing the nasal cavity, remove any clots if they are present. If required, do an suction and remove all the blood and the clots what is present there. Then place an cotton wool soaked in adrenaline is important. Adrenaline, because it's a vasoconstrictor, powerful vasoconstriction. It causes a vasoconstriction, might help with stopping the bleeding. If this doesn't help, then what you'll be using, remove the cotton wool which is present there, which is soaked with the adrenaline. Visualize if there is any bleeding artery is present. If you can visualize a bleeding artery, then you can cauterize using a silver nitrate stick. But make sure if the bleeding is from both the nostrils, you cannot cauterize on the both the sides. If you cauterize on the both the sides, chances of septal perforation will be on the higher side. One of the complications of a silver nitrate stick usage is the septal perforation. Bleeding has stopped by one of these interventions. That is, either you have placed an cotton soaked wool, you have placed it, that is basically a gauze piece, you have placed it and it has stopped it, or you have placed, or you have done an cauterization and it has stopped the bleeding. In both these circumstances, you will be observing for 15 minutes. Then you'll be discharging them. If the bleeding doesn't recur, then you'll be discharging with an antiseptic cream. What is the importance of an antiseptic cream? Antiseptic cream studies have shown that it prevents the recurrence, especially in the pediatric age group, and it has to be prescribed for 7 days. Okay, antiseptic creams like Naseptin, you can use it, or any antiseptic cream can be used. No, the bleeding has not stopped even with cauterization, or you cannot do a cauterization because you cannot visualize any bleeding artery. You have placed in cotton wool soaked in the adrenaline, it has not stopped the bleeding. At that point of time, you will be doing anterior nasal packing. This is a commercially available anterior nasal packing. We are using commercially available ones because it is easier, less skill is required to place this one. If that stops the bleeding, well and good, you will be admitting the patient, because you need to admit from here, you need to admit all the patients, you cannot discharge them. If it doesn't stop, for example, the bleeding was from the right nostril, you have placed an nasal tampon in the right nostril, the packing has been done in the right nostril, it has not stopped. Then you will be doing and packing on the other side, on the left side also. If that also doesn't stop, then you need to start thinking it might be a posterior bleed. Nowadays, a nasal tampon with a balloon on the posterior part is available commercially. You can use those. Sometimes the bleeding might not even stop with that. You need to involve the ENT on an urgent basis. Ask them to come to the emergency department immediately. All these patients needs to be admitted under the ENT. You shouldn't be discharging these patients. So when to admit? These are the three reasons. When you're done in packing, you need to admit it. It might be an only an single nostril you have packed, or a bilateral packing you have done it, or you're done it posterior nasal packing you have done it. Whatever the packing is, you always admit it. That is one of the indications. If it is a traumatic cause of epistaxis, this is a tricky part here. If it's a traumatic cause of epistaxis, there might be a base of skull fracture. If there is a base of skull fracture, it is a contraindication to place and nasal tampon there, because it can go up and injure your brain parenchyma. Risk will be there because the base of skull fracture might be there in trauma cases when they have an epistaxis. So you might have to do an imaging first before you think of placing an tampon. If the patient is hemorrhagically compromised, obviously you need to admit. Previous nasal packing was done in last 7 days itself. If the patient is on anticoagulant, significant amount of blood loss is present, suggestive of an hemoglobin less than 10 grams per deciliter. Uncontrolled hypertension, it will become an emergency, urgency and emergency here. You need to admit it. Significant comorbidities, especially heart-related and liver-related comorbidities are there, you need to admit. The patient cannot come back to the emergency department immediately because he's staying far away or he's staying alone. He's an elderly person. Again, in those circumstances, you need to admit the patient. A patient preference, it's very rarely considered, or you can consider in certain situations where patients really wants to stay back here, then you can consider, but it's not a must to admit these patients. No follow-up is required for the patients whom the bleeding has stopped with an first aid measure. So here, no follow-up is required. You have done a first aid measure. What is this? Just pinching the soft part of the nose, you have done it, and the bleeding has stopped. No follow-up is required in those circumstances. Rest all circumstances, they need to follow. For example, your cauterized, they need to follow up. Advice on discharge. Do not blow your nose at least for a week. Do not prick your nose at least for a week. If you're sneezing, make sure your mouth is open at least for a week. Do not eat anything hot or spicy, which will cause vasodilation, can cause bleeding, including alcohol. They shouldn't take it at least for 2 days. They shouldn't be lifting anything heavy or straining or bending over for at least a week. No vigorous activities, including going to the gym for at least a week. Picking up the nose should be completely avoided. Now coming to the topic of vertigo. Usually the patient presents with dizziness. Dizziness is an layman's term. Dizziness might mean an vertigo, might mean an presyncope. So what is presyncope? He feels like he's gonna lose his consciousness is known as presyncope. It is treated and the differential diagnoses are very much similar to that of the syncope, which I learned in the cardiology chapter. Here what we are learning is a vertigo. The description will be I have the spinning sensation. I feel like room is spinning around. That kind of sensation he'll be having. That is in medical terms, it is known as vertigo. In emergency department, it is important for us to differentiate a peripheral vertigo from an central vertigo. Central vertigo for us, it is an posterior circulation stroke. Remember, it is an posterior circulation stroke for us until and unless proven otherwise. Whenever you're suspecting an posterior circulation stroke, you need to always get an MRI scan done. CT scan is waste. Posterior circulation strokes cannot be visualized on a CT scan. You need to always depend on an MRI scan done. How to differentiate clinically a peripheral vertigo from an central vertigo? The symptoms both are kind of sudden itself. The spinning sensation, the vertigo, the spinning sensation is more predominant in the peripheral. Nausea and vomiting is quite significant in the peripheral vertigo. Auditory is more peripheral. CNS symptoms are more central for obvious reasons. Then you will be doing a test known as hint examination. In hint examination, only HI stands for head impulse test, which will be abnormal in peripheral. N stands for nystagmus. Nystagmus are usually vertical or bidirectional in a central vertigo. Rest everything comes as a peripheral vertigo. Skew test. Vertical skew is seen in central vertigo. No skew or absolutely normal skew test is seen in peripheral. I will be talking more about head impulse test in vestibular neuritis. Let me talk more about test of skew here. What is test of skew? You will ask the patient to see straight forward and fix his gaze. Then you will cover one of the eyes. Once you immediately remove the cover, what you are having, for example, you have placed a hand over his eyes, you remove your hand immediately. Then the eye position will be in the same position. This means no skew is seen. Okay, there is no skew at all in this patient. In an affected, for example, someone is having a central cause for vertigo. At that point of time, again, you'll ask the patient to fix his gaze. You cover one of the eyes, immediately remove the cover. The eye position will be downwards and slowly it will be going into the neutral position. This is known as vertical screw. So it has vertically come down and slowly it gets corrected once you remove the cover what you had. This is known as vertical skew. It is highly suggestive of an central vertigo. Nystagmus. Nystagmus also differentiating factors you need to be aware of. One thing you need to be aware of, here you can see in the image what I am having here, it goes very fast in this direction. That is known as fast phase. And it goes slowly back in this direction. That is known as slow phase. Have a closer look here. It goes very fast in this direction, going little bit slowly in this direction. Fast is fast phase, slow is slow phase, it is known as. Usually peripheral vertigos are horizontal. If it is vertical or bidirectional, you need to think of a central nystagmus. Effect of gaze. Gaze remains in the same direction regardless of change of the gaze. That means what happens? Sorry, nystagmus remains in the same direction regardless of direction of the gaze. So, for example, if you're seeing on the left side, also the nystagmus remains in the same direction. That means the fast phase remains in the same direction. If you look on the right side, also the fast phase remains in the same direction. Here, the fast phase can change. That's why it is known as bidirectional. If you look at the left side, the fast phase might be on the left. If you look at the right side, the fast phase might change it to the right side. That's why it is known as bidirectional, which is very much suggestive of an central nystagmus. Effect of gaze. If you see towards the fast phase, the nystagmus might get worsened. There is no effect on the gaze at all in the central nystagmus. Fatigue. Over the time, it might get fatigued, then again increases. So it might be fluctuating over the time. Effect of fixation gate. If you fix the gaze, nystagmus might even get disappeared or nystagmus can decrease. Here, it will be still persisting uniformly. Causes of peripheral vertigo are important. It can be a benign positional vertigo. It can be inner ear infection that is known as labyrinthitis. It can be a Meniere's disease. It can be a middle ear infection. Okay, it can be sometimes foreign body in the ear. Central cause for us, it is always and stroke, posterior circulation stroke, that is vertebrobasilar insufficiency, which is the blood supply for the posterior part of your brain. So posterior circulation stroke, we are suspecting unless and until proven otherwise. There are other causes also like meningitis, abscesses, post-traumatic it can be, subclavian steal syndrome can be. We have already learned about subclavian steal syndrome in the last class in the vascular chapter, or it can be an multiple sclerosis also in this patient. But remember, stroke is the most important differential diagnosis for and central vertigo. It is a stroke for us in central vertigo unless and until proven otherwise. Peripheral vertigo has different differential diagnosis. Coming to acoustic neuroma, in some literature says it is a central cause, some literature says it's peripheral. I have taken this from OHEM and I am saying that it is a peripheral cause. Okay, so depends on the literature which you are following. How do you treat an vertigo? A symptomatic treatment usually is given by an anticholinergic properties which are having antihistamines, cyclizine. Cyclizine is available orally, or you will be going prochlorperazine is the second preferred one. It is advantage is it is available in intramuscular form. Most of these patients, because of spinning sensation and loss of balance, they will be having vomiting. For that reason, you may not be able to give the drug orally. So it is preferred to give intramuscularly in the parental route. So prochlorperazine is preferred most of the time because you can administer it intramuscularly. Cyclizine is only available in tablets, has to be given orally. If you're planning to discharge these patients, strictly advise them not to drive till the vertigo comes down. And this has to be documented in your notes and also be conveyed to the GP through an email or through a letter. We will be seeing each one of these differential diagnoses. Now, first one is benign positional vertigo or benign paroxysmal positional vertigo, simply known as BPPV. In BPPV, you need to remember that he has the vertigo, the spinning sensation in only in certain positions. It is more positional, only in certain positions. In certain positions, there will be no spinning sensation at all. He feels completely all right. That is the classical thing what you need to pick up from the stem of the question. What happens? What is the pathophysiology here? In semilunar canals, there is some debris which gets accumulated. Because of the presence of this debris, this semilunar canals cannot work appropriately, resulting in imbalance, having the spinning sensation and nausea and vomiting what they present with. You can confirm this by doing an Halpix test. How do you do it is not important. It's important in the OSCE here. And you can treat it by doing another maneuver known as Epley's maneuver. If you're unable to perform an Epley's maneuver, at that point of time, you will involve the ENT. Or the Epley's maneuver is not beneficial. You're tried 2 times, then again you will be involving. You'll be having recurrent episodes of BPPV. More than 3 episodes he had, recurrent episodes are at that point. And the symptoms are persistent and it is recurrent for 4 weeks. He is suffering, involve the ENT. Meniere's disease classically presents with a triad of tinnitus, that is ringing sensation, with fluctuating ear loss. Most of the time, it is a sensorineural ear loss along with an spinning sensation, that is a peripheral vertigo. What happens here? Idiopathic endolymphatic hydrops. That means inside this inside the semilunar canals, there is a liquid. That liquid gets increased for some reason. Exact reason is not known. That causes distortion of the balance. That is nothing but resulting in spinning sensation, vertigo. Vertigo will result in nausea and vomiting in this individuals. So excess of endolift productions, we do not know exactly what happens, but it occurs in the semilunar canals, which results in menisthesis. Most of these patients would have already been diagnosed with a menisthesis, and they come with worsening of the symptoms. Vestibular neuritis. As the name suggests, it is a viral infection of a neuron. Vestibular neuron viral infection has happened to this. So it will be a predisposing viral infection. A few days back, I had a viral infection. I just took down the counter drugs and I have recovered completely now. But now I am having the spinning sensation. It's a classical history of vestibular neuritis. Vestibular neuritis is persistent. It is there always. In any position he will be having. But in certain positions, it gets worse. So remember that vestibular neuritis will be present always, but it gets worse in certain positions. It doesn't get disappeared in any positions. If it gets disappeared in certain positions, then it is known as BPPV. There will be no hearing loss. There will be no neurological deficits for obvious reasons. It's a peripheral cause and no hearing loss will be present. The important thing is the head impulse test. What do you need to look at? How do you do an head impulse test? Head impulse test, what you'll do is you'll ask the patient to look forward and fix his gaze. You'll hold the head and suddenly you will turn it to one side. Here we are turning it to his right side. You can see still the gaze will be fixed. If the head impulse test is abnormal, the gaze will go towards the face where it is turned and slowly it get back to the normal position where you are asked the patient to fix his gaze. This is known as corrective cascade. Corrective cascade is seen only in vestibular neuritis. It is highly specific for vestibular neuritis. It is not seen in central vertigo at all. So it is in vestibular neuritis if the head impulse test shows corrective cascade, or in simple terms, if it is positive. Acute labyrinthitis. Acute labyrinthitis, inner ear infection we are talking about. It's the inflammation of the labyrinth. The inner ear has got inflamed. Inner ear is affected here, so some amount of hearing loss will be there in these patients. Otoscopy must be done to look for any evidence of infection is there. You will be referring if there is significant amount of hearing loss is present. Again, symptomatic treatment. Here also it is symptomatic treatment. Acoustic neuroma is a tumor. Neuroma is a tumor. It's a vestibular schwannoma, what we call it. It's basically a tumor. Tumor is found at the cerebropontine angle. So this is the cerebropontine angle what we are having. Tumor is found at this point of time. There are other cranial nerves also here present here. So there can be fifth and sixth cranial nerve also might be involved here. This patient, the important term what you need to be, gradual hearing loss will be there. It's a gradual thing that helps to differentiate from the menisthesis. Gradual hearing loss, what we'll be having, not significant hearing loss like in menisthesis. Here, anyone presents with an just an vertigo with an sensory neural deafness, which is gradual, it is an acoustic neuroma until and unless proven otherwise. Remember, gradual hearing loss with an vertigo, it is an acoustic neuroma until and unless proven otherwise. In manias, this is not quite gradual as you see in acoustic neuroma. This summarizes more. BPPV is episodic in certain positions. Only he has the vertigo. In vestibular neuritis, it is persistent. Persistent. It will be. It gets worsened in certain positions. There is no hearing loss in both BPPV and vestibular neuritis. Here, head impulse test is positive. Acute labyrinthitis is inner ear infection. That's why you will be having certain amount of hearing loss. In mania disease and acoustic neuroma, in all these three conditions, you will be having an hearing loss will be present. Head impulse test or hint that includes head impulse test, nystagmus, and test for skew. Studies have shown that this is as sensitive as an MRI scan to differentiate between an central vertigo towards and peripheral vertigo. Head impulse test, corrective cascade will be present. That is seen in vestibular neuritis. In central, there will be no cascade at all. He will be able to fix his case. In nystagmus, it is unidirectional. In peripheral, here it will be bidirectional. It will be present. Or it might be a vertical one. Here, it is an horizontal one. Test of skew, there is no skewing is seen. Vertical skew is seen in central vertigo. How to test the hearing loss? Can be tested, have been tested previously. There are two tests to check the hearing loss. what basically you want to differentiate, or you want to know whether hearing loss what the patient is having, is it an sensory neural deafness or is it an conductive deafness? Conductive deafness means the sound which is entering into your external auditory canal through the tympanic membrane, through the middle ear, going into inner ear, something is wrong here. Then it is an conductive deafness what the patient is having. Okay, sensory neural deafness is the one where there is something wrong with the eighth cranial nerve, vestibulocochlear nerve. There is something wrong with that now. Then you call it as a sensory neural deafness. Neuron is affected there. So what we do, there are two tests to. One is Renin's test, another one is Weber's test. How to do the Renin's test? In Renin's test, what you do is strike the tuning fork, place it at the mastoid process. He will hear the vibration sensation. Once he stops hearing, then you will place it in front of the ear. When you place it in front of the ear, if he's still able to hear it, that means air conduction is better than the bone conduction. This is a normal finding. This isn't Rennes test. What happens in sensory neural deafness? Sensory neural deafness, still air conduction will be better than the bone conduction. In conduction deafness, bone conduction will become better than the air conduction. So what will be the finding? In conduction deafness, what will happen is when you place this tuning fork over the mastoid process, he'll be hearing. Then you'll ask him to tell you when he stops hearing. Once he stops hearing, you will place it in front of the ear. He'll not hear anything. That indicates that bone conduction is better than the air conduction, which is seen in conductive hearing loss. Next, coming to the Weber's test. In Weber's test, what we'll be doing here is you will place the tuning fork after striking it over the vertex. In normal individual, in both ears, he will be able to hear it equally. Okay. What happens if there is a conductive hearing loss? For example, the patient is having symptoms in this ear. In conductive hearing loss, he will be hearing it better in the affected ear. Okay, remember that in the affected ear, he will be hearing better. Hearing better is known as lateralization. So he'll be having lateralization towards the affected ear. Affected ear, he'll be able to hear better, he'll say. What happens in a sensory neural deafness? In sensory neural deafness, he'll say that he's able to hear better in the normal ear. That is, lateralization is towards the normal ear. So this is lateralization to the normal ear, what I have mentioned here. So this tabular form is very important, tested previously in the exam. People get confused here. So be aware. In sensory neural deafness, Rennes test remains normal. That is, air conduction will be better than the bone conduction. And Weber's test lateralizes. That means he'll be able to hear better in the normal ear. In conductive deafness, Rennes test, bone conduction will be better than the air conduction, and he'll be able to hear better in the affected ear in the Weber's test. That is nothing but lateralization to the affected ear. Few more things you need to be aware of. Persistent unexplained hoarseness of voice or unexplained neck mass, if it's present, it is an laryngeal CA, what you need to suspect. Okay, persistently it is there, months together is there, hoarseness of voice, and there is a neck mass, it is not tender, there is no obvious cause. Think of cancer in those circumstances. As as you grow older and older, there is loss of cochlear hair cells. In inner ear, there are something known as hair cells which pick up the sound and converts it into an neuronal impulse. This hair loss will result in hearing loss. This is known as presbycusis. This is sensory neural deafness what the patient will be having. This is nothing but stone in the salivary glands. Most of the time, it is submandibular gland. There is sublingual gland, submandibular glands are present. It is most of the time submandibular glands. If you ask him to open his mouth, you might be able to see a stone there. It is obstructing, the stone is obstructing the flow of the saliva. What happens? How's the classical presentation is? He says that whenever I have food, I have severe pain, because whenever you have food, it salivates. Whenever he salivates, the secretions are not coming out. Because of that reason, he'll be having severe pain, especially for sore things like lemon juice. If he's drinking, a lot of saliva is trying to be secreted. It will not come out. It will cause more and more pain. Sometimes even giving the sore, like a lemon juice giving to him, if more secretions are secreted, the stone might be dislodged, and that might be a treatment. Otherwise, we will be just referring them to the ENT surgeons. One more thing I just missed to say, that in peripheral vertigo, the treatment remains is symptomatic. Peripheral vertigo, you can discharge them or you will be discharging them, and the treatment is symptomatic. You're not doing anything specifically. Central vertigo, you need to treat it like a stroke, what you learned in the neurology chapter. Ludwig's angina, very important. It is a true emergency you need to be aware of. In the stem of the question, they will mention about a dental procedure or a dental infection. Some toothache they'll mention, or some tooth extraction will be there. So some dental procedure or an infection or something related to the dental, something related to the teeth, they will be mentioning. What is Ludwig's angina? This is nothing but cellulitis of the spaces which are present below the tongue, below this region, the cellulitis here. So what are the regions? Submandibular, submaxillary, and sublingual regions, there is an cellulitis. This cellulitis is not a normal cellulitis. It is a necrotizing cellulitis, what you are having. This, because of the cellulitis, there is swelling which develops. Because of the infection, swelling has developed and it pushes the tongue upwards. As the tongue is pushed upwards, airway obstruction can happen. This can even lead to death also. So whenever the patient is having signs and symptoms suggesting of a threatened airway, for example, he's having drooling of saliva, he's not able to swallow anything, he's struggling to talk or struggling to swallow. At that point of time, immediately involve the anesthetics and involve the ENT. That is important. This is the step one. No, he is not having any signs and symptoms of partial obstruction or in threatened airway obstructions. At that point of time, you will be starting them on broad spectrum antibiotics and you will be admitting them. Admission is a must in these circumstances. Before I go into the ophthalmology, we'll take up questions. Skew test, any eye can be done and cover for how long? You have to just cover for a few seconds. Any eye can be done. There is no logic by doing it. You can do any eyes. Usually it is done for bilateral, both eyes it has been done. Unilateral, bilateral is bidirectional. The fast phase, what we are talking about here, about the nystagmus, you have the question about the fast phase. Fast phase, it changes. If it changes, for example, here the fast phase is towards this side. If the gaze changes, the fast phase might change to the other opposite side. This is known as bidirectional. If the fast phase remains this side itself for this person, even though if changes his gaze, then it is known as unilateral. Now we are entering into the ophthalmology. It is a little bit of anatomy is required for you to understand better of the pathology here. First thing is you have the outermost layer cornea. Cornea is a completely transparent what you will be having. Inner to the cornea, you have the iris. This is the iris. Between the space between the iris is known as pupil. What you look black color, it is known as pupil. This iris can constrict or can dilate. Constriction will cause mydriasis, that is basically larger pupil size. Meiosis is dilatation of the iris, what is talking about. Behind the pupil, you will be seeing a lens. Lens is attached to the ciliary body. Lens is hanged by the ciliary body. Both the ciliary body and iris together is known as anterior uvea. Ciliary body and iris together is known as anterior uvea. Posterior uvea is choroid. This, what you're seeing, this lining, what you're seeing here, this is known as posterior choroid. All right. Anterior uvea is also, sometimes in some literatures, they might just call it as an iris. Behind this, you have the retina here where the light falls. And you have an optic disc. Optic disc is here. Just behind the optic disc is the optic nerve which will be running. Just opposite to the pupil, what you will be seeing on the retina, it is known as macula. Retina usually converts the light into the electrical impulses and send it to the brain so that an image is formed. First, we'll be seeing of the nerve lesions. Nerve lesions is lateral rectus, superior oblique, and third cranial nerve, that is oculomotor nerve. What we'll be looking. First, we'll be looking at the lateral rectus. Lateral rectus supplied by sixth cranial nerve, also known as abducent nerve. This is the lateral rectus. What is the function of the lateral rectus? Lateral rectus is to pull the eye towards the lateral side. So you want to see the lateral gaze, this gets constricted, this muscle gets constricted, so the eye gets pulled towards the lateral side. You need to remember in the normal gaze, when you're looking forward, what happens? When you're looking forward, there is some amount of muscle tone which is present in the lateral rectus, some amount of muscle tone which is present in the medial rectus. It will make sure the eyeball remains in the center because you're just looking forward, just you are having a central vision, what you're having. When you are looking towards and side, for example, you're looking towards the lateral side, the lateral rectus will contract, the medial rectus will relax so that it goes towards the lateral side. It becomes easier for the lateral rectus to pull. Now we'll imagine there is a lesion. Lesion is where in the sixth cranial nerve, that is the abducent nerve. In abducent nerve, because of the lesion, there is a paralysis of this one. That means there is loss of tone. There is no tone at all. There is some amount of tone is present in the medial rectus here. So in normal position, when you ask the patient to look forward, the eye will be more towards the medial side. That means more towards the nasal side, nose side it will be. That is the normal position what you'll be having. Let's just have a look here. In the normal positions, is the sixth cranial nerve. You can see eye is toward the affected eye is this one and it is towards the nose. What happens if you ask the patient to look towards the affected side? This eye medial rectus will relax. So the eye will come to the midline, but it will not go towards the lateral side because the lateral rectus is not contracting. That what will happen in that circumstance? See here, you're asking him, this is the affected here. You're asking him to look towards this one. The normal eye will go towards this one, but the affected eye remains in the middle. That's why what will happen in your brain, there are two images which are produced from each eye. One image is a different one. This image is a different one. That's why you will having two images. A diplopia will occur. A double vision will occur. The eyes should be coordinating with each other. That's when both the images will overlap with each other and you will be having an crystal clear image at that point of time. If the coordination is lost, you will be having an diplopia. That's what happens here in the sixth cranial nerve palsy. The next one we are seeing is the fourth cranial nerve palsy. Fourth cranial nerve is also known as trochlea. Fourth cranial nerve supplies superior oblique. The function of the superior oblique is to pull inwards and towards the nose. Okay, it is inwards and downwards. Towards the nose, it is pulling inwards and downwards as the arrow, inwards and the downwards what you are having here. If the tone is lost, what will happen in the resting position when you ask the patient to sleep forward? It will be going outwards and upwards is the resting position what you'll be having. Whenever you ask the patient to look inwards and downwards, when do we look inwards and downwards? Most of the time when you're climbing stairs. When you ask the patient to look inwards and downwards, he'll be having double vision. So this, when you ask the patient to look straight forward at, you can see the normal eye position is outwards and upwards what the patient is having. When you ask the patient to look inwards and downwards, he'll start having diplopia. That's why the classical history here is for the, sorry, superior oblique trochlear nerve, whenever it is altered, he will complain that whenever I climb stairs, he is having diplopia. That is the classical history. Last one is third cranial nerve palsy. Third cranial nerve palsy supplies all other oculomotor nerves, oculomotor muscles. Sorry, it supplies all other extraocular muscles. So as it supplies all other extraocular muscles, the sum total of the effect will be in the resting position, downwards and outwards will be the resting position. And what will happen? He will have an diplopia. So this is the position. He will have an diplopia whenever he sees towards the normal eye. That means whenever he sees this side, he'll have a diplopia because this is the normal ear. So take home message is everything what is mentioned in this tabular form. If you're not able to remember the images, at least remember what is given in this tabular form. Third cranial nerve, they'll have a diplopia looking towards the normal eye. Eye position is important. It is downwards and outwards. Along with an diplopia, this patient can present with a dilated pupil. Ptosis can be present along with the diplopia. A dilated pupil is mainly seen because closer to the third cranial nerve, there is the parasympathetic nerves which are running. This also gets injured whenever there is a third cranial nerve injury, resulting in dilatation of the pupil because there is no parasympathetic stimulus. Sympathetic stimulus will take over. We know increased sympathetic stimulus will cause dilatation of the pupils. Lateral rectus, he'll have diplopia whenever he sees towards the affected eye. That is the lateral gaze. Superior oblique, downwards and inwards, that is climbing stairs, he'll have diplopia. Inferior rectus, what are we talking about here? Inferior rectus. This is from the trauma chapter, what I picked up and kept here. In inferior rectus, that is nothing but floor of the orbital floor fracture. Inferior rectus gets stuck here in the floor of the orbital floor fracture. It gets stuck in the fracture site. So he cannot look upwards because this cannot relax. It has got stuck there. So he'll not be able to look upwards at all. For that reason, he'll have diplopia whenever you ask the patient to look upwards on an upward gaze. There are various differential diagnoses for an red eye. Each one of this will be seeing now. The few things you need to be aware of is Whenever he comes with in contact with a person with a similar symptoms, and at that point of time he developed a red eye, think of an infective conjunctivitis. It is very, it spreads very quickly and very fast. If it is associated with inflammatory bowel disease or a joint disease, what inflammatory bowel disease I am talking about? Crohn's disease or ulcerative colitis. Joint disease is ankylosing spondylitis. I'm talking about. If the patient has one of these following, think of anterior uveitis. If the person is wearing a contact lens, think of corneal ulcers, because this is a foreign object can cause infection. He has an atopic illness, like person is a known case of asthma or hay fever. Think of allergic conjunctivitis. Depending on where is the redness, again, you can think of differential diagnosis. If it is a generalized, think of an conjunctivitis. If it is localized like this, what you are saying, think of an episcleritis. If it is circumcorneal, also known as perilimbal, what you're seeing here, think of acute angle closure glaucoma. Anterior chamber acute angle closure glaucoma, what do you need to think about? If there is blood in the subconjunctival space, as you are thinking here, most of the time it is in subconjunctival hemorrhage, and no treatment is required for this. Just reassure and discharge. Nothing needs to be done for this. Usually tested in lab exam, can appear in your exams also. So each one of this will be having it. First is conjunctivitis. It's nothing but infection or inflammation of the conjunctiva. This inflammation or the infection might be because of bacteria, might be because of viral. Bacteria, strep pneumonia can be there, viral adenovirus can be there. In sexually active persons, it can be an retus. This is also known as reactive arthritis, what we have learned in previous chapters. This usually presents with urogenital symptoms will be there. Urethritis will be there along with the conjunctivitis. If present, think of an sexually transmitted diseases, especially chlamydial infection you need to think of. If the patient has an hay fever and asthma, think of an allergic conjunctivitis. Usually it will be seasonal. Treatment for this is just prescribing antihistamines should be sufficient. Other than this, it is very difficult to differentiate between a viral and a bacterial clinically. So the recommendation is anyone who presents with a conjunctivitis other than an allergic conjunctivitis, always prescribe them the antibiotics, either the fusidic acid or chloramphenicol antibiotics will be prescribing. These are all topical antibiotics. Either drops will be prescribing or as an ointment what will be prescribing. If the person is using a contact lens, tell them do not use the contact lens till the symptoms have completely subsided. Another thing you need to tell them is in the household, do not share any pillow, any towels, at least for 5 days after the symptoms have settled down. Okay. Not to return if the symptoms have not settled down, and they have to come back to the emergency department if the symptoms are not settled in 5 days, because it might be something else might be going on. Most of the time, we ask them to follow up with the ophthalmologist if the symptoms doesn't subside. Corneal trauma. Dust going into your eye isn't corneal trauma, foreign body what you are having. This is very commonly seen in, you might have experienced, I might have experienced previously. It is a common thing which happens very commonly. So it can be anything blown into your eyes, basically. Foreign body, if they are traveling at a high velocity, it can cause perforation. It can perforate your orbit. So high velocity, if it is there, then you need to be very careful. When you're examining for the foreign body, sometimes the patient might say, whenever I blink, I have that foreign body sensation. Otherwise, I do not have a foreign body sensation. That means it is stuck somewhere in the upper eyelid. You need to avert the upper eyelid, then look out for the foreign body. It can be easily averted from the subtarsal. Sometimes you might have to put and dye and have a look for the foreign body. See, in the slit lamp examination, they say something is there, doctor. Something is irritating my eye. Something went into my eye. Just put some dye and observe in a slit lamp. You can easily observe the foreign body. The foreign body will take up the dye and it will appear bright in color. Very rarely, there will be some vitreous hemorrhages, hyphema. This is nothing but pus collection we are talking about. Sometimes if the pupil penetrating injury is there, irregular pupil might be there. Even the visual acuity might be affected. What are you seeing here? This is also known as foreign body. What has happened here? This is typically known as rust ring. What has happened here is foreign body is here. Over the foreign body, epithelial tissue has developed. That's why it is known as rust ring. This, if you leave it foreign body for a few days, epithelial tissue will develop. This they need to just follow up with the ophthalmologist. They will remove it. It is difficult to remove it in the emergency department. How to remove the foreign body now? Just irrigate with the normal saline. just ask them to wash their eyes with the normal tap water also they can wash, or you can irrigate them with the normal saline. If unsuccessful, then you can use a cotton bud and try to remove it. Before using cotton bud, it is recommended that you use the local anesthetic drops. It is not always a must. It is just a recommendation because it will be much more comfortable for the patient and it will be much patient will be more cooperative. If cotton bud is also unsuccessful, at that point of time, you might have to use a needle and remove it because the foreign body has been impacted in the corneal epithelium. You need to just scratch a little bit and remove it. Needs to use and slit lamp examination. If you're doing this, it is highly recommended that you use an local anesthetic before you use a needle. If still it is unsuccessful, you need to refer to the ophthalmologist. Do not do anything in the emergency department. Topical antibiotics is always recommended, especially in contact lens wearers, and anti-pseudomonal antibiotics like an aminoglycosides needs to be prescribed for these individuals. Previously, they used to recommend that use cyclopentolate to relieve the pain. It is no longer recommended. It is found to be not effective. They're no longer. For the pain management is oral analgesia what we'll be giving in this individual. iPad is not at all recommended. It's big no. What is iPad? iPad or eye patch, you call it, is the one and the same thing, eye patch or iPad. What you do is you take a gauze press and place it over the eye and place some tape over it. This will cause more pressure over the eye. If there is a foreign body, it can cause more injury to your eye and more injury to the cornea. For that reason, absolutely no. If they have any visual loss of visual acuity, they shouldn't drive it till there is complete back of vision. Anywhere in ophthalmology, do not give steroid topical drops. For any reason, do not give any steroid containing topical drops unless it is recommended by the ophthalmologist. You will not be prescribing on your own steroid topical for any reason. Same thing holds good for topical anesthetic like local anesthesia like a lidocaine topical. It is available. It might be a good pain management for the patient. You shouldn't be prescribing because of the well-controlled pain, he'll not realize what is happening to his eye. For example, the foreign body still might be there and it might cause a corneal ulceration. He'll not even realize and the healing might be worse. For that particular reason, topical anesthetics are not prescribed or you shouldn't be prescribing to that person. What about tetanus prophylaxis? For corneal abrasion, tetanus prophylaxis is not required. Corneal ulceration, yes, it is required. Penetrating traumas. So high velocity penetrating traumas, sometimes the X-ray, if you get it done, you can see it and usually it damages the iris and the iris might have got herniated in this manner. Okay, this is a typical picture, multiple times tested in the exam. This is suggestive of a penetrating trauma. So orbital X-ray might be required if the foreign object is radio opaque, you can pick it up. Apply an eye shield. Eye shield is this one. It is a hard part where there is some cooling is present and it will not have any pressure over the eye. So it's a hard part what is there and it is like this cooling, it will be there so that it takes the contour of your eyes and it will not cause any pressure and you just apply the tapes over it. This one is preferred, not eye patch is not preferred. Give them some analgesia. Tetanus prophylaxis is absolutely required because it has penetrated and gone inside. Everyone requires an urgent ophthalmology reference here. So in blunt trauma, if this is nothing but blood has accumulated, this is known as hyphema. This is also an hyphema where clot has formed. This is clot has not formed. That's why it is accumulated downwards. A clot has formed here. That's why you're looking this in an enlarged way. Ocular burns. By chemicals I'm talking about, it might be an acid or an alkali. What will happen? Acid will have the pH very much on the lower side and alkali will have the pH very much on the higher side. So just use an litmus paper, place it over the eye. Then you will know what is the pH of the eye. If it is on the higher side, then start irrigating. If it is on the lower side, also start irrigating till the pH comes back to the normal. That is till the pH comes back to the 7.4. Failure to doing this, you need to immediately refer to the ophthalmologist. Nothing can be done in the emergency department. You need to refer to the ophthalmologist. Once you have done this one, you need to do a slit lamp. Once the pH comes back to the normal range, do a slit lamp examination using an fluorescent stain, looking for if there is any corneal damage, especially any corneal ulcers are present in this individual. You need to have a closer look. Another thing you need to remember here is police sometimes use something known as CS spray. This CS spray contains chlorobenzylidine malonitrate. what happens here? You shouldn't irrigate for these individuals. If you irrigate, it reacts with the water and it will cause more injury. So what you'll be doing is you'll be making the patient stand close to a fan, and on the fan, through the air, it will be blown outwards. Just the idea behind it. Do not irrigate here at any cost. Now we are entering into the corneal ulcers. Corneal ulcers are also known as keratitis. Ulcer is discontinuation of any tissue. Here, epithelium discontinuation, what we are talking about. It is not an aberration. An ulcer has happened here. So breach in the corneal epithelium, what has happened? It might be because of a trauma. As we told, a severe penetrating trauma, or sorry, corneal aberration can result in a corneal ulcer, or an infection can result to it. Okay, so this is a trauma, what you're seeing. Here is the infection, what you're seeing here. It is difficult to just differentiate it just on an fluorescence lamp examination. Depending on the presentation, it might be punctate. This is the punctate. It might be rounded. It might be dendritic. Dendritic is very important. This is the dendritic suggestive of an herpes simplex virus infection. Unilateral, painful, photophobic injected eye, they present to the emergency department. So any keratitis or corneal ulcers should urgently be referred to the ophthalmologist. Important point, they should be urgently referred to the ophthalmologist. Any, doesn't matter if it is a herpes simplex or it is a traumatic, any ulcers present, you need to refer to the ophthalmologist. If it is an herpes simplex virus, along with the referral, you will be prescribing them ganciclovir, or you can prescribe them acyclovir. Ophthalmic drops are preferred. Oral is not preferred. Ophthalmic drops are preferred, mainly because orally acyclovir is available. Acyclovir is notorious to cause acute kidney injury. If you give it orally, the systemic effect is very minimal. It directly acts on the eye itself. So topical is always preferred. Oral is not preferred for an corneal ulcer caused by herpes simplex. Remember this image multiple times. It has appeared in the exam. And do not forget, all these patients needs to be referred urgently to the ophthalmologist. Superficial keratitis. Superficial keratitis is nothing but what you are seeing here is arc eye, also known as snow blindness. It is a less serious ulcers. Okay, small ulcers, multiple ulcers, what you are seeing here. Most of the time, it is because of the exposure to the UV light. It is commonly seen in welders, or you go seaside and you're doing a sun bath without using any sunglasses. In those, it is commonly seen. They commonly present with pain, watering of the eyes. Classical history will be present. Multiple punctate small ulcers, what you're seeing here, will be present in these patients. NSAID eye drops are available. You can use it. Cyclopentolate is kind of not recommended. If the pain is severe, you can ask them to take oral analgesia also, like an ibuprofen, and and reassure them it kind of resolves within 24 hours. Nothing needs to be done. So superficial keratitis need not be referred to the ophthalmologist. But here, corneal ulcers, what you are having, you need to definitely refer to the ophthalmologist, because it can worsen and patient might have loss of visual acuity. Permanent visual acuity loss might be present. Acute angle closure glaucoma. What happens here? Little bit of anatomy we need to be aware of. Ciliary body produces aqueous humor. This ciliary body produces aqueous humor, and this is a liquid. It passes from here, goes up, enters into the anterior chamber, and it gets drained in the trabecular meshwork at this angle. If this angle for any reason it becomes small, this cannot get drained. This gets accumulated here, resulting in increased intraocular pressure. Classical finding of an acute angle closure glaucoma. Resulting increased intraocular pressure will result in severe pain. Along with the severe pain, systemic symptoms also start appearing, like an headache, abdominal pain, vomiting, nausea. All those symptoms will start appearing. What are the reasons? A dilated pupil, a shallow anterior chamber, a lens growth, all this can result in narrowing of this angle. So as I told you, systemic symptoms like headache, abdominal pain, nausea, vomiting can be present. Classically on examination, the pupil will be mid-dilated. Mid-dilated means it will be 3 centimeters. Approximately it will be 3 centimeters. And it will not react to light. No afferent light reflex will be there. It will not constrict or dilate. If you flash the light, it will not constrict at all. And erythema will be predominantly be seen around the eye. This is not a classical image here. Circumcorneal erythema, that is around the cornea, you will be seeing erythema, that is red color you will be seeing. So circumcorneal erythema, raised intraocular pressure will be seen, mid-dilated unreactive pupil will be seen. Sometimes loss of visual acuity might be seen, decreased visual acuity, then complete blindness will be seen. This is a true emergency. Intraocular pressure needs to be reduced. For reduction of intraocular pressure, you can use acetazolamide, mannitol is available, beta blockers are available. There are 3 drugs which will help you to reduce the intraocular pressure. After 1 hour of starting the initial treatment, then you can start giving them pilocarpine. Okay, it basically causes constriction of the pupil. Constriction of the pupil what will happen? This will open up the angle here. Constriction of the pupil will result in opening of the angle, trabecular meshwork angle here. That will help to drain it. It is useless to give it in initial 1 hour. Initial 1 hour, you should always target to reduce the intraocular pressure by reducing the secretions of aqueous humor, production of aqueous humor from the ciliary body. Pain will be severe. Morphine might be required in these patients. Urgently refer to the ophthalmologist. They might be requiring an iridectomy. Basically, open up here angle, just cut open a little bit of iris here, or make an hole there, that is known as iridotomy. Anti-eye uveitis, very important. Every exam, every diet, they have a question appearing from an anti-eye uveitis. Again, just to recap, what is the anti-uveitis? The iris, this is the iris part, and this is the ciliary part. Combined together, it is known as anterior uveitis. Inflammation of the anterior uvea, is known as inflammation of the anterior uveitis is known as inflammation of the anterior uvea is known as anterior uveitis. Itis means inflammation. So what happens here? So it is inflamed. Once it is inflamed, strictures can form between the iris and the lens. That's why the pupil will become irregular and accommodation will be quite painful. The pupil dilatation or constriction will be very painful in these persons because there are some adhesions which are developed between the lens and that of the iris, and the pupil will appear irregular. You can see in this image, classically, it is appearing irregular. As this is an inflammation, an infection, an inflammation, sorry, not an infection, it's an inflammation. What is happening? You'll start seeing inflammatory cells in the anterior chamber, especially on the slit lamp examination. Because these inflammatory chambers are present in the anterior chamber here, multiple inflammatory cells are present. Light gets reflected from this, and the patient, it appears like an floaters for him. He says, I can see various floaters, doctor. Along with it, there is perilimbal erythema can be seen similar to that of the acute angle closure glaucoma in this individual. If you remember from the previous classes, I keep on saying that anti uveitis is one of the HLA-B1037 disorders. So it can be associated with ulcerative colitis or an Crohn's disease or an ankylosing spondylitis can be present. If past medical history is suggestive of an ulcerative colitis or ankylosing spondylitis and he has presented with a red eye, it is an anti-uveitis, which is also known as iritis until and unless proven otherwise. Light photophobia, basically because pupils will start constricting. It cannot constrict because there is some adhesions which are formed between lens and the iris. That's why they'll have quite a bit of pain, especially during accommodation. What you need to remember, circumcorneal erythema, as I've explained, irregular pupil will be present. That is another classical features you need to be aware of. What about intraocular pressure? Intraocular pressure is decreased because aqueous humor is produced by ciliary body. Here, ciliary bodies are affected. That's why intraocular pressure is decreased. You need to urgently refer to the ophthalmologist. Steroid drops are given only on advice of the ophthalmologist because it's inflammatory reaction. Steroids will be helpful here. But as I told you, a thumb rule is we never prescribe and steroid drops in for eye until it is recommended by the ophthalmologist. Scleritis, there's something known as scleritis, where the deep episcleral vasculature is involved. Episcleritis is where superficial vasculature is involved. When deep scleritis, that is basically deep episcleral vascular structures are involved, what will happen? That will result in color change of the sclera. It becomes more blue in color, as you can see in this image. And this will cause thinning of the sclera. Thinning of the sclera will make it quite brittle, and there can be globe rupture can happen or globe perforation can happen in these people. Okay, remember, blue color and thinning can result in perforation. It is caused by inflammation of the deep episcleral vascular plexus. It is commonly associated with other inflammatory disorders like rheumatoid arthritis or vaginous granulomatosis. What you do in the emergency department is you basically do a pain management and immediately refer to the ophthalmologist. One more classical finding on examination is they'll be having quite a painful eye movements. Why they'll have quite a painful eye movements? Because on the sclera is the extraocular muscles which gets inserted. Because the sclera is inflamed, whenever they move, the sclera is stretched. If the sclera is stretched, they will be having severe pain because it is inflamed. So the things to remember in scleritis is it is associated with other inflammatory disorders like vaginous granulomatosis or an rheumatoid arthritis. Deep episcleral vasculatures are present. On examination, you can see blue color sclera, and sclera is quite thin, so it can perforate easily. If you ask him to move around, that means lateral gaze, medial gaze, if you ask him to move his eyes, the movements will be quite painful because extraocular muscles gets inserted over the sclera. Urgent ophthalmology reference is the treatment, or that's what you will be doing in the emergency department. Only analgesics can be provided. There is no specific treatment what you can do in the emergency department. Contrary to scleritis, episcleritis is quite benign. It just involves a superficial episcleral vasculature. And they present with this kind of erythema where it is quite localized. Localized congestion, what you will be seeing. If red color, which is quite localized, it is present, it is diagnostic of episcleritis. What you'll be doing is you'll be just prescribing them oral antibiotics and some topical NSAID drops like an ibuprofen eye drops you can prescribe them. They will present with more like an irritation rather than pain. Pain is more seen in scleritis. Orbital cellulitis versus periorbital cellulitis. It is important to differentiate orbital cellulitis from an periorbital cellulitis because orbital cellulitis is treated like a severe infection, nothing but it's treated like an sepsis with IV antibiotics and admitting the patient. For that reason, we should be able to clinically differentiate between orbital cellulitis from that of the periorbital cellulitis. The important structure, what you need to remember is orbital septum. There is a superior orbital septum, this one, and there is an inferior orbital septum, this one. This orbital septum prevents the infection to spread from the surrounding structures into the orbit, into the orbit. It prevents the spread of the infection. That is very important for us. This structure is very important. That's why it is rarely seen because of the presence of orbital septum. How to differentiate? Any eye symptom is present, it is an orbital cellulitis for you. They present with chemosis, proptosis, some inflammation can be there seen outwards. Okay, any eye symptoms. Along with it, they will be having quite a painful eye movements and restricted eye movements will be present. That is known as ophthalmoplegia. Loss of visual acuity can be present in these patients. As this is a severe infection, there will be systemically unwell. There might be septic, tachycardic, tachypneic, hypertensive, there might be. Receding remote infection is very commonly seen in an orbital cellulitis. So remember, any eye symptoms if present, it is an orbital cellulitis unless and until proven otherwise for you in the examination. The important ones, what you need to remember is eye movements will be painful. There will be restriction of the eye movements. Chemosis and proptosis will be present. Chemosis, this is chemosis, this is proptosis, propped out, popping out. Eye has popped out. Management cellulitis, like in sepsis, what you need to treat it, orbital cellulitis, so broad spectrum antibiotics needs to be given, urgent ophthalmology reference, and get NCT scan done if the patient is immunologically stable in the emergency department itself, because if there is an abscess formation, it might be requiring an drainage. When drainage is recommended, whenever the visual acuity is affected, whenever there is loss of pupillary reflex is there, or you're given the IV antibiotic, the patient is not improving. These are the indications to perform an surgical drain. Why are we worried about orbital cellulitis so much? Because this can cause permanent loss of vision, including death and sepsis can occur in these individuals. That's why we are very much worried about an orbital cellulitis in these patients. Rest, rest of the things are also important, but the major things what you need to remember is this one can cause cavernous sinus thrombosis. Remember that complete vision loss, septicemia, cavernous sinus thrombosis can ask, and it can spread to any surrounding structures. Few other presentations, what you need to be aware of. Blepharitis. What is blepharitis? When they are matting of the eyebrows, when the matting of the eyelashes is present, then it is known as blepharitis. It will be quite itchy presentation what they'll be having. It is because of the infection. There is some secretion of the pus resulting in matting of the eyelashes. What you'll be doing, you'll be just prescribing them the topical antibiotics and ask them to follow up with the GP. There are two conditions. One is external hordeolum known as style. Another one is internal hordeolum known as chiasson. External means externally it is there. What happens here? This is an inflammation of the eyelash root. Eyelash root here has got inflamed. He'll be coming with a severe pain. Just in warm compressions should be sufficient here. Here, what happens in internal hordeolum? Internal, it is inside the eyelid. There is a gland known as meibomian gland. This gland might get obstructed and resulting in infection. If that has occurred, then topical antibiotics needs to be prescribed, and you will be referring if the abscess or a nodule is there which is affecting the vision, then you need to refer to the ophthalmologist. Lacrimal sac infection, also known as dacrocystitis, which is present here. That is the medial aspect here, because your tears gets drained into this lacrimal sac. That's why the name is lacrimal. Lacrimal means tears. This itself can get inflamed. This is mainly seen whenever there is a lacrimal duct obstruction. Initially, if it is not abscess formed like this, you can see clear-cut abscess. If this is an abscess, you need to admit for IV antibiotics and drainage will be required. If this is not very significant, only certain amount of erythema is present and a mild inflammation, mild swelling is present, at that point of time, you can just prescribe oral antibiotics and ask them to follow up with the ophthalmologist. If something significant like this or like this in the image, what you're seeing definitely requires an IV antibiotics admission for drainage. Sudden vision loss. Sudden vision loss broadly classified into painful and painless. It is important to be aware of, because in the symptoms, when the patient presents and he says that I do not have any pain, but I cannot see anything, then you need to suspect these three things. I have severe pain, I cannot see anything. Then these are the differential diagnosis. What are the painless visual loss? Painless is central artery occlusion or a vein occlusion or retinal detachment. Painful vision loss, painful optic neuritis seen in my multiple sclerosis. It can be temporal arthritis. Remember that painful we are talking about. In migraine also it can be, and visual loss can be seen. Painful we are talking about. This is headache what we are talking here. Headache what we are talking. Here is the eye pain. So they'll be having some pain we are talking. We're not literally saying that it is always an eye pain. In glaucoma, it is an acute angle closure glaucoma. Again, it is an eye pain here what you'll be seeing. Central retinal artery occlusion. This is an end artery. So there are various causes. It might be an AF where the emboli has got dislodged and has obstructed the central retinal artery occlusion at the end itself. So various predisposing factors will be there. Pupillary reflex will become quite sluggish and sometimes it might be even absent. The classical fundal appearance you need to be aware of. An image can be given. This is known as cherry red spot. A pale retina is seen. This whole retina, sorry, the whole retina should be bright in color. What you're seeing here is quite pale. Along with pale, one spot you can see which is bright red in color. This is known as cherry red spot. This is a classical presentation, classical finding what you can get it on fundus examination. There are various proposed treatments for central retinal artery occlusion. None have been yet proven to be effective. Multiple studies are still required. There is scope for research still. What are the various options you have? Rebreathing of carbon dioxide. This will cause vasodilatation. Okay. This might dilate the central retinal artery and dislodge the clot. This is one of the thought. Timolol eye drops to reduce the intraocular pressure. Reducing intraocular pressure using an acetazolamide also might dislodge the clot. Massaging the globe might dislodge the clot. Using a dilator like an sublingual glycerol trinitrate might dilate central retinal artery, dislodge the lodge. You might thrombolize it, but requires again more studies. You can give an hyperbaric oxygen. Again, it is under studies. None of this have been proven, but at least few things you will be trying in the emergency department, hoping that this one of this following will be helpful. Again, everyone should be referred to the ophthalmologist. Central retinal vein occlusion, the classical fundal appearance is known as snowstorm appearance. A storm has appeared. It looks very bad. What has happened here? What are the things? These are dilated tortuous veins, what you're seeing here. This is known as cotton wool spots. The red one, what you're seeing is hemorrhages, what you're seeing. This is the papilledema, where you can see here optic disc is swollen and it is bulging. That's why I call it as an papilledema can be seen in these cases. There are various risk factors for an retinal vein occlusion like an old age, chronic glaucoma, atherosclerosis, hypertension, polycythemia. All of this are the risk factors. you cannot do much in the emergency department other than treating the risk factors for this patient. So you will be just concentrating on managing the risk factors. Nothing much can be done. Similar to that of the central retinal vein occlusion, here also there will be decreased visual acuity and afferent pupillary defect can be seen. In both conditions, this is seen. This will not help you to differentiate between central vein or an artery occlusion. The fundal examination which helps you to differentiate it. Here, classical pale retina with a cherry red spot is seen. Here, classical stormy sunset appearance is seen. Vitreous hemorrhage and retinal tear. First, we'll be looking into the vitreous hemorrhage. What is vitreous hemorrhage? What is this? Behind your lens, where ciliary body is there, beyond your lens and between the retina, there is a liquid which is present. This is known as vitreous body. 99% of it is just and plain water. As you grow older and older, it can get liquefied and it can start collapsing or it can start accumulating here due to the gravity. But that is not important for us. What is important? How does the bleeding occur? Vitreous hemorrhage is there is a bleeding which is in the space, there is a bleeding. That is in the vitreous, there is a bleeding. There are plenty of vessels. If the vessel is abnormal, neovascularization causes abnormal. What is neovascularization? Diabetes will cause occlusion of the normal arteries. To supply the blood, there are new vessels which have developed. Those vessels are known as neovascularization or new vessels. Neovascularization is nothing but new vessels. These new vessels are quite brittle. They are prone for rupture, resulting in bleeding. Certain medical conditions also can cause neovascularization, like in sickle cell anemia, which will cause sickling of the RBCs and obstructing this end arteries. Normal vessel rupture can happen because of a trauma. How it happens is not important. Basically, because of a mechanical force, it causes tear and it can cause hemorrhage. If it is a mild hemorrhage, they will be just seeing some floaters because it will be obstructing for the rays of the eyes. So hemorrhage, some blood is there. It will be obstructing for the rays of the eyes to fall on the retina. That's why they will look, some floaters will be seen. If it is a large bleed, it is obstructing complete the ray of the light to fall on your retina, then there might be loss of vision. So loss of visual acuity can be seen in large bleeding. Red reflex loss will be there. What is red reflex loss? Red reflex is basically if anything which obstructs the ray of light to fall on the retina, it will cause loss of red reflex. Because whenever the light goes and hits the retina, it reflects back. It appears as if a red color when you do an fundal examination. So this is normal. This is abnormal. There is no light is reflecting from the retina when you do an fundal examination. That is suggestive of an absence of red reflex. Commonly seen because of retinal tear, because there is no retina to reflect it back. Vitreous hemorrhages, you can see it. It is also seen in cataract, where there is increase in density of the lens, so light cannot pass through it. So the red reflex will be absent. These are the circumstances what you need to remember where red reflex can be absent. Retina, you might not be able to visualize under frontal examination. So frontal examination, the main finding is absence of red reflex. What you'll do is you'll ask the patient to sit head up to allow. What is head up? You'll ask the neck to be hyperextended so that the eyeball becomes in this manner and the blood gets accumulated here in the posterior chamber. Then immediately you'll refer to the ophthalmologist, because most of the time vitreous hemorrhages are associated with an retinal tear. Now let us see what is retinal detachment, or in simple terms, what is retinal tear. Retinal tear, as the name suggests, it gets torn. Okay, the attachment gets torn. And so there is no retina here, it gets attached and torn. When it torn and it starts falling down, patient will feel like as if the curtain is coming down. That is a classical description of this. There are few risk factors what you need to be aware of. It is seen in elderlies, myopes, diabetics. Following at trauma, it is very commonly seen. They will classically describe it as an curtain which is coming down. Because there is no retina, their red reflex will obviously be absent. Visual acuity also will be severely affected because retina is required for you to for you to convert the light rays into an electrical impulse and transmit to the brain. If there is no retina, then you will not be able to see. So there will be significant loss of vision. Visual field defects will be there. If it is complete retinal tear, you might not see. Complete blindness might be there in those patients. This is one of the painless causes for loss of vision. You need to immediately refer to the ophthalmologist for a surgery so that they can reattach the retina. Optic neuritis is a component of myasthenia gravis. Here, the what has happened is there is inflammation of the optic nerve. They classically initially presents with red desaturation where they cannot appreciate the red. If you ask the bright red color to be seen, either they will say that it is more pinkish or more orangish color. They will not tell it is red in color. It might be associated with swelling of the optic disc known as papilledema. This is, again, you need to remember, commonly associated with multiple sclerosis, which we have covered in our previous chapter in neurology. Amaurosis fugax. This is nothing but an TIA of the eye. Okay. Temporary arterial occlusions causes an TIA. Same thing happens here also. In eye, if it happens, then it is known as amaurosis fugax. It is a transient loss of vision will be seen because of obstruction of the central retinal artery. It is a transient thing which has happened. Usually it lasts for 5 to 15 minutes. There are various causes for this, from temporal arthritis to emboli to an atheromatous diseases, acute angle closure glaucoma, or hypercoagulability, or raised intracranial pressures. Various causes are there which all requires further evaluation. If someone presents with this requires and further evaluations, you can think of starting them on an aspirin if it is not contraindicated, like in TIA what you started, but this patient needs to be further evaluated because eventually they might have a complete vision loss because of the central retinal artery occlusion. Before we go into the recalls, I'll just go into the questions. If anyone of you anti-uveitis versus acute angle closure glaucoma in presentation, there are lots of acute angle closure glaucoma will have symptomic, sorry, systemic symptoms like abdominal pain, nausea, vomiting will be there. Along with it, it is a mid-dilated pupil they will be having, and it is not reactive to the light. Anterior uveitis will present with painful circumcorneal erythema, which can be seen on the both sides, but the pupil will be irregular. Inflammatory cells can be seen in the anterior chamber of the eye. Along with it, the patients are usually associated with other HLA-B27 disorders like an ankylosing spondylitis or inflammatory bowel diseases can be seen in this individual. And the pain will be quite worse in both situations during the accommodation, what you need to be aware of. As you can see, there are various differentiating factors between an anti-uveitis and acute angle closure glaucoma. Highly unlikely you get confused between the both. Now we'll enter into the recall questions. The first one is a 23 years old male present to the emergency department with an abdominal pain. His GP said that might be suffering from an glandular disorders and prescribed symptomatic treatment. Glandular fever is nothing but Epstein-Barr virus resulting in infectious mononucleosis. This, he has no known comorbidities. What is the test to confirm the diagnosis? You know the diagnosis. This is the diagnosis. How do you confirm the diagnosis? You confirm the diagnosis is more than 12 years age. So less than 12 years, serology will do it. More than 12 years, the first test is heterophile test, also known as Paul Bunyan's test, also known as monopause test. So the right answer here is monospot test. A paramedic pre-alerted you for a 4-year-old child with an active seizures. On arrival to the emergency department, you receive the kid in the resuscitation bay and connect to the monitor. The child is post-ictal. On examination, you notice the image shown below. What is the likely nerve involved? What are we seeing in this? Unequal pupils, what we are seeing here. One pupil, this pupil is constricted. This pupil is dilated or more compared to this constricted pupil, what you are having. So what has happened here? Here, the third cranial nerve is involved, and the surrounding structure, that is the parasympathetic nerves which are around the third cranial nerves, are also got affected here. Because of the loss of parasympathetic innervation or parasympathetic stimulus, this patient has only sympathetic. Sympathetic will cause dilatation of the pupil. That's why the pupil is dilated. This one, this is nothing but uncal herniation. Okay, this patient has an uncal herniation resulting in pressure over the midbrain. In midbrain, you have third cranial nerve. This third cranial nerve is surrounded by the parasympathetic nervous system. Loss of parasympathetic nervous system will result in increase in sympathetic tone, results in dilatation of the pupil. So this is the left ocular motor nerve which is involved. This side, this is the right, this is the left. So left ocular motor nerve which is involved or culprit here. A 19 years old present to the ED with a nosebleeds, vital parameters are fine. You pinch the cartilage, doesn't stop the bleeding. Sorry. You pinned the cartilage pass of the nose to stop the bleeding, which was unsuccessful. Hence, you have removed the clot from the nasal cavity and cauterized. Cauterization was done with an silver nitrate. The bleeding has stopped. What is the most likely complications? Cauterization is prone for septal perforations. So be aware of septal perforations can happen because of the cauterization, one of the complications. A 49 years old present to the emergency department seeking immediate medical attention. He complains of sudden loss of vision is there for last few hours. It is associated with an headache and vomiting. On further questioning, he has right eye pain also. What is the most probable diagnosis? So it is an painful vision loss what the patient is having. Painful vision loss, we have three differential diagnoses. One is central retinal artery occlusion, central retinal vein occlusion, and retinal detachment. Sorry, it is in pain free. This doesn't have any pain. This is a pain free one. Painful one, what we have? Acute angle closure glaucoma we are having. Is that present here? Yes. So these are all are pain free what you are having. Visual acuity, vitreous hemorrhage, partially visual acuity, not complete vision loss. What you're seeing here will be seen in these circumstances. Again, vitreous hemorrhage also will cause painless vision loss. Here, acute angle closure glaucoma causes painful vision loss. Here, the simple question is, which one of the following is indicative of an central cause of vertigo? Unidirectional horizontal nystagmus is suggestive of an peripheral visual learn. Bidirectional vertical nystagmus is seen in central vertigo. That is the right answer. Tinnitus, head impulse positive is seen in vestibular neuritis. Tinnitus can be seen in Meniere's disease. Nystagmus remains in the same direction regardless of change of the direction. This is known as unidirectional. In other terms, it is a description of unidirectional nystagmus. Again, it is commonly seen in peripheral vertigo. So the right answer here is the second one, straightforward question here. The patient has presented to the ED with the redness in the eye. She denies any visual loss or any discharge from the eye. No similar complaints in the past. Image has been given. Which of the following symptoms is associated with this condition they're asking? Let us have an, sorry. Let us have a closer look of the image. In the image, what you can see, the pupil is irregular. It is not completely round. It is irregular like this. Whenever the pupil is irregular, we are always thinking of an anterior uveitis. In anterior uveitis, which one of the following is very commonly seen? Pain during accommodation is very commonly seen. Blurring of the vision is not seen. Floaters are seen. Purulent discharge is not seen. Purulent discharge usually in conjunctivitis, bacterial conjunctivitis, you'll be seeing. Permanent vision loss, this is not a cause for permanent vision loss. Mid-dilated pupils are classical feature of acute angle closure glaucoma. Along with it, you're seeing something here. What is this? This is nothing but pus has accumulated here. This is known as hypophona. Hypophon, it is known as. A 56 years old male came to the emergency department with difficulty in swallowing and neck pain. He is a known case of diabetes and hypertension. Underwent tooth. Whenever his tooth comes, I am always suspecting Ludwig's angina. Image has been given. You can see here below this, it is quite enlarged. Tongue is protruding outwards. I'm strongly suspecting of an Ludwig's angina here. This cannot be any other diagnosis here. I'm thinking of a Ludwig's angina because of presence of a dental procedure or anything related to the tooth. If present, it is an Ludwig's angina until and unless proven otherwise. A 10 years old boy who has undergone an tonsillectomy 7 days back has presented with an bleeding he has observed on the pillow. He's tachycardic in the on presentation. No active bleed is observed, but there is some purulent discharge which is seen. What will be the next step here? What are we suspecting? We are suspecting here this patient to have an delayed post-tonsillectomy bleed because 7 days back, anything more than 24 hours, up to 14 days, we call it as a delayed post-tonsillectomy bleed. Delayed post-tonsillectomy bleed, most of the time it is because of an infection. So this patient will require IV antibiotics and admission. Along with it, it is better to get an full blood count, RFT, like in sepsis you are treating, get a throat swab to the purulent discharge what is present. Cross-matching to be on the safer side. If there is significant blood amount of loss is there, you can cross match the blood and transfuse them. For that reason, cross matching might be helpful in this patient. So fifth one is most appropriate here. A 60 years old lady came to the ENT department complaining of spinning sensation. So it is an vertigo for us. And unsteadiness from yesterday. It increases when moving and continues even at rest. This is important phrase. Increases when moving continuous even test. So it is a persistent one what the patient is having. Along with this, the patient is having a positive head impulse test. They're asking what is the next best step. So keeping all this in mind, what are we thinking about? There is a vertigo which is persistent with an head impulse positive. That itself is enough for you to make a diagnosis of vestibular neuritis. It is a vestibular neuritis what the patient is having. What is the treatment for vestibular neuritis? For that matter, what is the treatment for any peripheral vertigo? It is basically prescribing them the symptomatic treatment. Prochlorperazine, which can be given intravenous form, discharge them on prochlorperazine will be the right answer here. You need to remember that if it is in PPPV, the treatment of choice changes. You will be giving these drugs to make him symptomatically better, but Epley's maneuver is the best one. Remember the Epley's maneuver you will be doing in the emergency department before discharging. A 34 years old male present to the emergency department with a sore throat and fever. He is a known IV drug abuser. The vital parameters are completely stable. Throat is shown here, which is quite inflamed. It is a tonsillopharyngitis, what the pharyngotonsillitis, what the patient is having. They are asking what is the investigation of choice. So basically, two investigations we spoke about, either do and throat swab or do and Paul Bunnell's test for EBV. This is for group A beta hemolytic streptococci. Both have been given here, group B hemolytic streptococci. Which one you will be choosing? We recommend you to choose group B hemolytic streptococci for that one throat swab for the strep you will be choosing for. The main reason is if this is positive, you can prescribe them the antibiotics because this patient is an IV drug abuser. You can consider this patient to be immunocompromised and antibiotics will be required. If EBV, if you get it done, Paul Bunyan's test, if you get it done, if it is positive, you just make a diagnosis. Still, it remains a symptomatic treatment. The treatment will not change. For that reason, we recommend you to choose the third one over the Paul Bunyan's test. A worried mom has brought the child to the emergency department. He was apparently well this morning. He was completely well. He was playing in the garden while the mom noticed there is some changes in the eye and the eye has started irritating. The image of the eye is given here. What is the next management plan? First, what are you seeing in the image? You're seeing an chemosis. Chemosis is conjunctiva is basically swollen and it is red in color. It is seen mainly because of conjunctivitis. This patient is having conjunctivitis. We are more thinking of this patient might be having an allergic conjunctivitis or might be having an viral conjunctivitis or might be having a bacterial conjunctivitis. We cannot differentiate with the findings what they are given. Because he has gone to the garden here, he might have acquired anything. So what we'll be doing for this patient? We are strongly suspecting this patient, which one? Bacterial, viral, or allergic. Most of the time, we will not be able to differentiate. Here, we are suspecting an allergy because he has gone to the garden. There might be some pollen grains. What we'll be doing for the chemosis? For chemosis, this is an inflammation, you antihistamine. Okay, preferred. What about steroids? Can we give steroids? We never give steroids without ophthalmologist's advice. So never choose steroids at all. Refer to the ophthalmologist. Most of the time, conjunctivitis, it will resolve in 7 days. Nothing needs to be done. Just an antihistamine eye drops. And usually we prescribe antibiotics. Also, these patients, topical antibiotics should be sufficient. They're basically asking here, not a feature of anterior uveitis, which is not a feature. Pain on accommodation, WBC in the anterior chambers. Yes, it is seen because it's an inflammatory disorder. Irregular pupil, yes. Perilimbal, also known as circumcorneal erythema, yes, seen. These are all suggestive of an anterior uveitis. Raised intraocular pressure is not a feature of anterior uveitis. Same question had appeared instead of not a feature of anterior uveitis, they had changed it by asking which is not suggestive of anterior uveitis. Raised intraocular pressure is not suggestive of anterior uveitis because ciliary bodies are usually involved, which produces the aqueous humor, which will result in low intraocular pressure. A 45 years old male brought to the MS department with complaints of burning vision and pain in the right eye. The symptoms are associated with floaters and headache. He has a significant past medical history for a lower back pain, which he is taking regular medications. He's completely stable now. What is the most likely diagnosis? Past medical history is important. This history can be because of an ankylosing spondylitis this patient is having, which is an HLA-B27 disorder. HLA-B27 disorder, if present, we are always thinking of an anterior uveitis, also known as iritis. Floaters, this patient is having. Floaters are because of presence of inflammatory cells in the anterior chamber. That is presence of WBC in the anterior chamber. That's why we are choosing an anterior uveitis here. They have given the image here. They are asking what is the likely diagnosis. What are we seeing in the image here? In the image, you can see that the eye is outwards and downwards. Outwards and downwards classically is suggestive of oculomotor nerve lesion, third cranial nerve lesion. Optic neuritis will not change anything. Optic nerve involvement usually will cause vision loss. This both can have different positions, but here it is not. For example, abducent nerve usually will be on this side while we'll be having trochlear nerve. Usually it will be pulled in this way. So the eye position will be here. Outwards, outwards and upwards is seen in trochlear nerve lesions. In abducent nerve, it will be deviated to the opposite side. That is basically it will be deviated to the nasal side. 36 years old male, a known case of Sjogren syndrome. What is Sjogren syndrome? Sjogren syndrome is a condition where the secretions decrease. For example, salivation will decrease, lacrimation will decrease, everything will decrease. When this decreases, calculi formation, that is a stone formation, increases drastically. We'll continue with the stem. Pain and swelling around the submandibular joint is seen. Pain is worse while eating. This is a classical history. Whenever there is worse at eating and they ask you for diagnosis, it is an calculi. Pick option number 1. 50 years old present to the ED with complaints of swelling at the base of the mouth. He had the third molar teeth extracted few days back. On examination, his vitals are stable. Right side swelling is noted and it is tender. What is the next best step in the management? Tooth present. It is always for us. What are we thinking about? We are thinking about Ludwig's angina. It is a Ludwig's angina until and proven otherwise. Anything in the stem of the question, is it suggestive of an airway obstruction or impending airway? Nothing is suggestive of that. That's why we'll go to the next step where we get a CT scan done because the patient is stable and we get an IV antibiotics. CT scan is important for the surgeons mainly because they want to see till where it is extending so that they can plan their surgery accordingly. The 30 years old female present to the ED with painful eye movements. She is a known case of type 1 diabetes, regular insulin for the same, and the observations are given. High grade temperature is there. Picture is given here. What's the probable diagnosis? Pictures will not help you to differentiate. Remember that picture often proptosis if they are given or a chemosis they are given, that will help. This picture is not at all clear-cutly suggestive of an orbital cellulitis. It can be a periorbital cellulitis also. Only if they're given a picture of an proptosis or the picture of an chemosis, then suspect an orbital cellulitis based on the picture. I'm still suspecting an orbital cellulitis in this patient because of the painful eye movements. So the right answer here is orbital cellulitis. Image is given. They are asking what's the probable diagnosis. Let us see the image here. This is the tonsil what you are having. Behind the tonsil, there is a swelling present. This is a peritonsillar abscess, also known as quinsy. They're just asking the diagnosis. So it is a straightforward peritonsillar abscess what the patient is having. A 3 years old boy walked to the emergency department by his parents. He was playing with his cousin and fell on the floor and his face first and sustained injury to the nose. He started crying immediately after the fall. There is no loss of consciousness. Image of the nose is shown below. Was the diagnosis? Image what you are seeing, there is a swelling which is present here. That is suggestive of an septal hematoma. Similar to what I spoke about and cauliflower ear, septal hematoma also important. If you do not drain it, it will cause necrosis of the septal cartilage. Because septal cartilage is avascular, the surrounding structures which provide it the vascularity that will get separated with the hematoma. So you need to drain it in the emergency department. So whenever someone comes with a nose injury, a trauma to the nose, always examine the nasal cavity. No bleeding, I'll just discharge him epistaxis. No, that is not the right way. You will examine the nasal cavity, look for a septal hematoma. If present, you will drain it. Then you will be discharging. That's the importance of septal hematoma. A patient has presented with a sore throat. Young female, she is also having an abdominal pain, upper abdominal pain. She is complaining about. You already given paracetamol. Image is given. What is the causative organism? Image will not help you to differentiate between a bacterial and viral. For example, from a strep pyogeny to that of an EPV virus, it will not be helpful. But here they have given an abdominal pain. Abdominal pain is usually seen because of enlargement of the spleen, splenomegaly, which causes stretching of the capsule, resulting in severe pain. Sore throat is present there. Putting together, the causative organism should be an EBV in this circumstance or in this question. You are teaching a group of students about an acute angle closure glaucoma. Which of the following drugs needs to be avoided? You need to avoid any drug which causes pupillary dilatation. If the pupil is dilated, the angle will become more and more acute and it will cause obstruction and it can predispose acute angle closure glaucoma. A known case of acute angle closure glaucoma do not give, it can worsen the condition. Which of the following conditions which of the following drugs can cause dilatation? Anything which has an anticholinergic effect or any drugs which are sympathomimetics can cause pupillary dilatation. Here, both TCA and SSRI, tricyclic antidepressants and SSRIs are are anticholinergics. They have anticholinergic properties. Both can cause. So both of this is the right answer. I am expecting that they might have removed this question next time around. They might just give one of this. So be aware of these two drugs. For that matter, any anticholinergic or an sympathetic drug, if they take it, that causes pupillary dilatation, that can predispose an acute angle closure glaucoma. The similar question has appeared in September 24. A 59 years old male was driving a two-wheeler without wearing a helmet. Something fell in his eye. He was not able to make out what was it. Post-incident, the patient is having a pain in the right eye. The image is given. What are you seeing? Image. The pupil is uniform, but you can see one of the side here, it is not uniformly round, which is present. This is suggestive of a penetrating foreign body which has gone. It's a classical image. Twice they have asked, they might ask you further. This itself is a giveaway diagnosis. You're seeing a dendritic lesion. Dendritic lesion is suggestive of an herpes corneal ulcer due to herpes simplex. It's a dendritic lesion what is present here. They're asking treatment. We need to give drops, acyclovir or ganciclovir. Here, out of this following, ganciclovir is present. Remember, oral is not preferred because of the side effects what you are having. That's why they recommend us initially you prescribe eye drops. If they're not getting better, then you can prescribe an oral acyclovir when they follow up with the ophthalmologist. Remember that all these patients who have ulcers needs to follow up with the ophthalmologist. Urgent reference. They need to be usually within 24 hours. They need to follow up with the ophthalmologist. A 76 years old male present to the emergency department with complaints of hearing loss. That is important. In his left eye, he denies left ear. He denies any trauma. On examination, his vital parameters are within normal. His external ear appears to be normal. You decide to do Rennes and Weber's test. Which one of the following is indicative of an sensory neural deafness? We will, before going into the option and confusing ourselves, Rennes test. What happens in a Rennes test? In sensory neural deafness, in Rennes test, air conduction will be better than the bone conduction. This one we got it right. Next one is sensory neural deafness, what we are having. In sensory neural deafness, there will be in Weber's test, lateralization to the normal ear will be present. Which is the normal ear here? It is left, what they have mentioned, the affected ear. So normal ear will be the right side. So in left and right, air conduction will be better than the bone conduction. In Weber's test, there will be lateralization to the normal right side. So what they have given here? Lateralization to the affected ear? No, it is wrong. Rennie's test, air conduction will be better than the bone conduction on the left side. Yes, true. If this is present, then it will become conductive deafness. No lateralization is seen in normal ear. Bone conduction better than the right conduction, then it will become a conductive deafness on the right side, which is not affected at all. So the right answer here is the second one. So always, whenever they're asking about Rennie's and Weber's test, you first think what should be Rennie's and what should be Weber's test, then look at the options. Otherwise, you'll get confused. The image itself, cherry red color spot, pale retina is present. They're asking diagnosis here. I can directly go ahead and pick up a central retinal artery occlusion here rather than studying the stem of the question itself. They actually presented with a sudden vision loss, which is a painless. Image is clearly suggestive of an cauliflower ear. Cauliflower ear, hematoma has developed here. What you need to do? You need to immediately aspirate, compression dressing, and follow up with the ENT. If you do not aspirate and do a compression dressing, this patient can have avascular necrosis of cartilage. So that's why it is very important. Commonly seen in boxers or wrestlers, it is commonly seen. So they need to sustain an injury. Image is given. What is the most likely diagnosis they are asking? Image is again dendritic lesions are seeing. This is nothing but corneal ulcer due to the herpes infection, simply known as dendritic ulcer also. So the right answer here is the first one. 7 years old boy is brought to the MS department by his mother who has noticed blood over the pillow. He has tonsillectomy 7 days back. On examination, the child is still continuously swallowing. This is important. Vital signs, tachycardic, borderline blood pressure is there. Rest of the vital parameters are fine. What is the best next step in this patient? Continuously swallowing. That means he has something in his mouth. That's why he's swallowing. In these circumstances, that means he is bleeding. He's swallowing the blood. That's why he's not vomiting. He's not throwing up, or he's swallowing the blood because it is bleeding from the tonsils. Whatever the blood is accumulating, he's swallowing the blood. It is bleeding. That means they're asking what is the next best step. Always, whenever there is bleed in your face, there is bleed in your nasal cavity or in your oral cavity, chances of aspiration will be high. Always keep them upright. That is important. Calm the child and keep them upright to prevent the aspiration. The first one is the right answer here. ENT referral and IV antibiotics. Yes, IV antibiotics eventually will be required, but that is not the first step. Eventually will be required because we are suspecting and delayed tonsillar bleed here. Infection is the most commonest cause. ENT referral, yes. Blood cross and cross matching might be required depending on the other vital parameter, depending on the laboratory investigations. Tranexamic acid is not that helpful. Again, you can give it if there is as a part of mass hemorrhage protocol. But first step is always keep them upright. Which one of the following is indicative of sensory neural deafness? They're asking. In sensory neural deafness, first we need to see which side is affected. So hearing loss in the left side is affected. In left side is affected, first Rennes test is a sensory neural. So ear conduction should be better than the bone conduction. Rest of the following I'll rule out. This one is rule out. This one is rule out. Unable to hear whisper is very non-specific. It is not able to differentiate between a conductive and sensory neural deafness. Now we have two things available here. Out of the two things, Weber's test lateralizing to the normal ear here, normal ear is suggestive of a sensory neural deafness. So this one is the right answer. They're asking what is the diagnosis here. So it's a middle-aged man who has come in with complaints of vision loss in the left eye, accompanied by the pain. So it is a painful vision loss. The vital parameters are within normal limits. Image is given. Image looks like a mid-dilated pupil. Not sure whether it is reactive to the light or not because not given in the stem of the question. Which one of the following is suggestive of painful vision loss? Only acute angle closure glaucoma. Rest of the things will cause painless vision loss. You have clear-cut diagnosis here. Dendritic lesions are present. So it is an dendritic ulcer what you are having caused by an herpes simplex virus. What is the most appropriate management plan? Here, it was a little bit confusion last that oral acyclovir will not give it, so we will rule it out. Topical chlorphenicol that is given for bacterial, again we rule it out. Topical ganciclovir and steroid drops, you can rule it out this one also because steroid drops are only given on advice of the ophthalmologist. And in herpes simplex ARS, that is dendritic ulcers, it is contraindicated. It can worsen the condition. It's contraindicated here. Now we are left with two options. One is option 2, another one is option 4. Which one is correct here? Topical ganciclovir drops, yes, you will be giving, that is right. Self-referral to the ophthalmologist if no improvement. What did I say in my chapter? That everyone needs to be seen within 24 hours by the ophthalmologist. That is very important here because this can progress. They need to meet up with the ophthalmologist. This is not an self-referral. So same day referral to the ophthalmologist for urgent review will be the right answer here. Ophthalmologist can start on the eye drops. If required, even oral acyclovir they will be starting. But meeting up with the ophthalmologist is the most appropriate thing. So option 4 is not right. Option 2 is the right one. Most of them got confused. I do understand the confusion here because topical ganciclovir is the treatment of choice here and steroid we do not. This one you rule it out. So no, they have to follow up. Okay, that is the guidelines. What is there? They have to follow up. That's why I recommend you to choose option 2. This is from the pediatric chapter. Okay, which this one question was missed, so I put up here. Here is an 11 years, that is a teenager boy, has come in with a sore throat and since the morning and noisy breathing and difficulty in swallowing is there. There is some drooling of the saliva and stridor is present. You are suspecting an epiglottitis. So basically, they are asking what is the most commonest organism to cause in this patient an epiglottitis. Here, the most commonest organism is still Haemophilus influenza. Vaccine has not reduced the incidences of Haemophilus influenza. It has just reduced the age group. Because of the advent of Haemophilus influenza vaccine, it is very rarely seen in younger age group like 4, 5, 6. It is very rarely seen. It is more commonly seen in teenagers around 10, 11, and 12 years age group. Because of the vaccination, the age group has changed, but the most commonest organism still remains Haemophilus influenza. Anyone has any questions? You can ask me now.